Welcome. I invite all of you to join the workshop. This workshop is going to change the way we see the healthcare.
We want to share the process of the webinar with you. We will not be using Zoom and other kind of softwares because.
Good morning, everyone. Dear esteemed members of faculty, my senior and colleague. At the outset, myself, Dr. Archana Khare, offer a warm welcome to all of you on the behalf of my team. We are all aware of the endometriosis, a very notorious tissue of endometrium, lying outside but very difficult to diagnose and at the same time painful, causing lots of problems with women's well-being. It affects women across all age group and socio-economic strata. Endometriosis has no pathognomic signs or symptoms. It is therefore difficult to diagnose. Though the first reference of endometriosis associated symptoms are found in the Erb's papyrus as early as in 500 BC, the disease still remains unclear. Because of this, there is currently no satisfactory therapy for all the patients with endometriosis. This is the reason why our President, Dr. Anjali Jamma ma'am, planned why not to discuss this topic in detail with the help of SOGS Infertility Committee. We came with this CME. Today, you all will enjoy the delicious academic feast full of knowledge. I am sure our expert faculty will make our understanding of this condition much clear. Thank you and welcome you all.
So that is how
I request Dr. Supriya to start the session. Over to you, Supriya.
One more thing that people are confused about, they ask us that whether it is for newcomers or it is for established buildings. So this workshop will make sense for you.
Yeah, basically, what is this workshop is actually trying to how everybody is in the healthcare or wants to be in the healthcare or planning to be there. We will be giving very simple logic and logical answers. We helping even a non-medical.
Welcome, madam.
So anybody,
Madam, she is a great teacher and academician. She is head of department at OBGYN department at VM Medical College. Dr. Velanka, madam, she is director and consultant at Nirvana Nursing Home, and she is a past president of SOGS. Welcome. Over to you, madam.
Hello. Good morning, everyone. Endometriosis is a very important topic in obstetric and gynec because it presents with very vague and varied symptoms. And the symptoms are chronic and the disease is difficult to diagnose and even more difficult to choose the line of management. It will be easy for us to understand this topic as we have with us today Dr. Milind Shah, who is going to speak on the etiopathogenesis of endometriosis. I take great pleasure in introducing an international figure of our society, Dr. Milind Shah. He has been the president of ISOPAB, IMA Solapur, IHRF Infertility and High Risk Foundation, Vice President Foxy ISPAT. He has chaired many posts on various societies like Indian Society of Aesthetic and Regenerative, IAG, ISAR, and many others. He has been the reviewer of Obstetric Gynec Journal of India. He has been a faculty to various international societies. The list is big and impressive. He has been blessed with many other qualities. He is very social, helpful, cooperative, and has good management skills. And he also has detailed information about practical solutions to many difficulties related to government rules, office matters, and many other things. I welcome Dr. Milind Shah to deliver his lecture on etiopathogenesis of endometriosis.
Thank you very much, Aboli, for this kind introduction. Friends, it's indeed pleasure. It's always a pleasure to speak to your own society members because they are the one who nurture you. But you know, friends, when I received this invitation by Dr. Anjali, I was thinking I'm going to speak on medical management of endometriosis. And when the flyer came in front of me, I said, oh my God, now I'll have to study a lot because it is something related to the theory now. And you cannot believe whom I remembered. I remembered actually all my teachers because always believe in this particular quote by Ludwig. The problems are solved not by giving you information, but by arranging what we have known since long. And that's what actually we learned this from all my teachers since 1980. I know that my previous house posts, my PG days, my clinical practice, everything was very much empowered by these all teachers whom I respect. I'm so happy that few of them, Dr. Sardesai madam is very much here in the audience. I'm really happy for that. Of course, it is not teachers, also my society members, because whenever I conducted certain studies, certain programs, all this group was so supportive, so helpful to me for all my ventures. I can't actually forget them, and that's why I always remember AMOGS, SOBG, and all groups very much. I'm thankful to all of them, Anjali, Archana, everyone for this wonderful opportunity, and also the AMOGS office bearers as well for this opportunity. Friends, whenever we think of reproductive endocrinology, we cannot forget this gentleman. Can anyone identify who is he? Yes, he is Professor Spirov. You know, his book since 1970s, we are studying, we are reading, and we are understanding every time something new in that particular thing. And I'm so fortunate to meet him in one of the FIGO meeting and got a gift from him, his book on the OC pills. And that's why I always cherish this moment with everyone whenever I get a chance to speak on the reproductive endocrinology. Now coming to the endometriosis, a disease in which the glands and stroma grow in areas outside the uterus. They are mainly in pelvis, but also in the distal organs, we do find the evidence of endometriosis. These actually appear in the form of cysts or the adhesions, causes a great deal of menstrual pain, affects women of reproductive age, but now the concepts are changing as well, and always remains a hidden disease until other problems arise. So when people say the incidence is increasing, I always say that more than incidence, our outlook towards looking at that particular disease, our more and more actual usage of endoscopy has made this rise in the incidence rather than it is appearing as a new. We know that it is estrogen dependent disease, frequently resulting in substantial morbidity, severe pelvic pain, multiple surgeries, and impaired fertility. Clinically, it is defined as a presence of this tissue outside, but what we know that it's inflammatory reaction which causes all those symptoms. It is one of the leading cause, rather was leading cause of gynecological hospitalization and hysterectomy. But now with multidisciplinary approach and more advances in the field of medicine, there are a lot of things which are conservative, a lot of drugs which got invented, which we are using very effectively to avoid this last end, actually the treatment. It corresponds to the high association of many comorbid conditions, disease of theories, definitive cause or causes remain still under debate, though association with number of hereditary, environmental, epigenetic, and menstrual characteristics exist. And that's why we say that prevalence is now more, ranging from 2 to 50%, depending our vigilance in the diagnosing this particular condition. Because we know every time in our group also, we keep on seeing new science on the radiology, which we are going to learn from the coming speakers. We are finding so many new presentations. We know about the jelly form appearance, which was presented by Dr. Sanjeev Khut, and so many actually other things as well, which could be diagnosed, but sometimes underdiagnosed as well. Exposure to ovarian hormones appears to be essential. No known racial or socioeconomic predilection. Previously, we used to say that is more of the disease of Caucasian women. We used to say that is more common in the higher socioeconomic strata, but not so. Now we realize it doesn't have that predisposition, and severe disease may occur in families as well, because relative risk to siblings is 2.3 overall if we take into consideration. But suppose we take into consideration severe or the moderate disease, it is as high as 15 that need to be taken into consideration when it comes to the clinical practice. There are many risk factors, rather associations I would say, were actually presented in various papers could be the parity, early menarche, non-oral contraception usage, non-smokers, shorter cycles and long duration of low, and dysplastic nevus syndrome melanoma. So there are many such papers which need to be get authenticated once we get more and more data on that particular thing. But we have realized that 20 to 40% of infertile women and 5% of the fertile women have endometriosis. But surprisingly, another study came up of the laparoscopic sterilization cases, and they found 6 to 43% of women were having endometriosis. The teenagers are also very much affected by this particular disease. And as I told you, our diagnostic armamentum has spread so much that even on imaging, we are able to understand with all those markers, which we are very routinely using, like CA125, we are able to diagnose this condition quite at early stage, at least we suspect, and then we go further with the further investigations. Is it a very new disease? No, it is known as long as 1600 BCE. Schron described a female disorder in which ulcers were appeared in the abdomen, the bladder, intestine, outside the uterus, but it was not named by the endometriosis. It is a Samson, generally credited for providing first theory on pathogenesis and coined this term endometriosis very recently in 1921. But the first histological description was credited to von Rokitansky in 1860. The Cullen letter suggested that endometrioma resembled the mucous membrane of uterus, and then people started suspecting that yes, it is the endometrium which is coming up. Naturally, then all these groups who are working in the field of infertility and other areas, they started coming out with the guidelines, which kept on changing a lot as far as the diagnosis is concerned, staging is concerned, as well as the management is concerned. And since 1927, the groups are meeting very frequently till 2022, I can say about, because just next month we'll be having the issue at Milan, and there is another group which is going to study a lot, discuss a lot on the endometriosis as well. And similarly, this balance about the treatment options, surgical and medical, is going to get churned a lot in that particular ISHRE conference. I'm very sure few of you must be going to attend that as well. Now, as I told you about the increasing incidence, it is more so, are actually the insight toward the diagnosis has changed a lot. And now there is more trend for the conservative therapies which are occurring, which suggest a true increase in the incidence. Theories include delay of childbearing, as I told you, OCP less usage, exposure to environmental toxins such as dioxin. Because this particular paper is again very popularly studied by the clinicians. But what we were knowing, like I remember when I was giving my PG exam in 1985, these were the theories which were taught to us. The Samson's theory, which says about the retrograde menses and the peritoneal implantation. But again, people started saying, oh, it's not viable endometrium, how is it going to get implant? Then came the coelomic metaplasia theory by Mayer, where we found that low incidence of the pleural disease as well. Came Halban's actually theory of hematogenous or the lymphatic spray to the distant tissues, but does not explain gravity-dependent disease site. The immunological defect is another actually theory which came forward. But what is very new is genetic predisposition. And that we need to study a lot. And that's why this role of ECGRI come. What is ECGRI? I'm going to show that in the coming slides as well. They were thinking that it's in situ from Wolffian or the Mullerian duct remnants. That is the metaplastic theory. Coelomic metaplasia, Samson's theory, could be the stem cells may be playing a role in this particular occurrence of endometriosis. The main actually finding is infertility, for which patients they come to us. There's no known prevention for this particular disease. Specific menstrual characteristics may be associated, like decreased risk with the late age at menarche, shorter menstrual cycles with longer duration of flow. Family history cannot be undervalued because nearly 10-fold increased risk in women with first-degree relatives who have a disease endometriosis. As I told you, these environmental factors need to be studied a lot. no particular demographic, personality trait, or ethnic predilection. And that's what actually we want to study in this ECGRI again. There's an inverse BMI relationship, no definitive association with the nutrition, exercise, personality traits, or other lifestyle variables, which we all, those things we have included in our ECGRI. I'm very sure you must be getting interested to know what is this ECGRI, which is a quite pleasant surprise for all of you. And there are many studies which always keep on coming, and people say, whether the attractive actually female, they have the more endometriosis, but which was not supported. The autoimmune connection was thought about as well as the cancer, because histogenesis of endometriosis and endometriosis associated ovarian cancer is most mysterious aspect of pathology. You cannot believe, friends, a 22 years infertile woman, she came to us with severe endometriosis with even rectal involvement. When we took the biopsy, it turned to be a malignancy. We went further to treat her with a very extensive surgery with Dr. Faim as well. And we gave her a medical management. And to my surprise, I was thinking such an extensive malignancy, probably she must be having a lot of problems. But last month I got a call that she want to come for follow-up after 2 years, and now she's planning for pregnancy. I was surprised because I lost her follow-up after surgery, and I wanted to know more about her. Probably in the next meeting, I will be able to tell you what must have worked so well, because I remember I referred her to the Tata Cancer Memorial for the further management. Endometriosis may accelerate development of ovarian cancer by 5.5 years, and the epidemiological features on the association between the endometriosis and cancer still remain elusive. Why it happens? But one need to think about it. Think about this autoimmune diseases as well. Multiple chemical sensitivities, inflammatory bowel disease, food intolerances, allergies, and the chronic fatigue as well. But more so, we'll have to think about this hereditary, environmental, epigenetic, and the menstrual characteristics. And that's what actually our purpose would be, suppose if at all we want to get involved in this particular program. The role of the estrogen definitely is there in the endometriosis, because we know its role in the cell growth. But it's not the cell growth, it is always and always related to the aromatodes. And that's why we always say that these aromatodes need to be utilized properly in the management of endometriosis. And it is again related to the prostaglandins or the PG into cytokinase. And that's why it is understood that the aromatase is a key for the biosynthesis of estrogen. In patients, aromatase expression is higher in endometriosis tissue than in normal endometrium. The endometriosis tissue aromatase activity is stimulated by prostaglandin, and estrogen is synthesized by endometriotic tissue, stimulates growth of the lesions, leading to all those problems. And that's why all these inhibitors were very effectively tried in the medical management of endometriosis, like letrozole or the anastrozole and the danazole as well. Basically, one need to understand how this estrogen behaves in the utopic endometrium and the ectopic endometrium. But per se, many of the phenomena are similar. Like it works through its immune cells, leading to cell proliferation and the differentiation on the endometrial cells and leading to the menstrual bleeding. What happens the utopic? But whenever this retrograde menstruation, or per se, if at all there is vascular, the lymphatic circulation occurs, or thinking of this stem cell therapy, the same actually sequence happens in the ectopic endometrium as well, which leads to more invasion, more oxidative stress, leading to the more angiogenesis, implants, and leading to chronic inflammation. And we label that condition as endometriosis. Naturally, we need to think about the progesterone as well, because that has been again used a lot since years as well in the management of endometriosis. The progesterone in the healthy endometrium again causes cell proliferation, decidualization, apoptosis, anti-inflammatory effect, and anti-angiogenic effect. Similarly, in the ectopic endometrium, in the endometriosis as well, same thing happen, but the decidualization is impaired. This reduce apoptosis, reduce anti-inflammatory effect, and increase bleeding, leading to all those adhesion formations and the endometriomas. It is basically used for its anti-inflammatory effect, ideal for the long-term treatment, effective, inexpensive, and generally well tolerated. But we need to think about the side effects as well. The Royal College also thought about this progestins, but they also understood that the women respond to progestins, which response is always a very response. There are no known predictive factors, but around 75% of the patients receiving progestins experience a reduction in the pain. It is always necessary to make room to leave an empty space in order to allow correct things to arrive in your life. And that's what we need to think a lot about any particular entity, any particular disease. And that's why one need to think about the etiopathogenesis as well, though appears very theoretical, we need to correlate it with our clinical practice. Genetics nowadays has entered in every disease, every field as well. And there are biomolecular aberrations in the ectopic endometrium, dysfunctional immune response, anatomical distortions, and pro-inflammatory peritoneal environment may all ultimately be involved. There are three distinct disease entities, each with different pathogenesis. We know this, the superficial endometriosis, OMAS, that is ovarian involvement, and the deeply infiltrating fibrotic disease. There are 5 key processes of development: the adhesion, invasion, recruiting, angiogenesis, and the proliferation. And that's why the India thought about this, making a very systematic study of this ICMR initiated study on the ECGRI. That is clinical phenotypes and genetic regulation of endometriosis in Indian women. And fortunately, friends, I'm so happy to tell you that Shulapri is also very much part of that particular study, and I'm very proud about it. Because see, we need to see our own patients as well. Do you have a marker here? Yeah, good, yeah. So there are all these centers from south to north, from east to west, because we want to have everything very clear about the concept of this particular association of the phenotypic expression as well as the genetic involvement. And we'll be having a very systematic study on that particular thing. This is our group who work a lot in this particular initiative. And we are finding every time something very new when we started studying slowly. Still, the study is not complete. But when we thought about it, we thought, well, let us go very systematically. And then we told all our participants to have this particular certification as well of the Global Health Network, because whenever it is a clinical practice, there are certain things which we need to adhere as far as the ethics are concerned. And that's how all of us, we gave this exam to authentify ourselves for this particular study. And I'm very happy that I understood many new things in that. I'm also happy to see that, this first paper which we had sent to the British Medical Journal, which got published, where we just send them the protocol and our concept, but the British Journal was very happy. And I must say big thanks to all these other contributors as well for their wonderful, actually, the involvement in this particular project, which is a very exhaustive process, I will tell you. Because though we know it is a very common entity, the clinical and genetic research in India study aims to broaden our understanding of the clinical phenotypes and genetic risk associated with endometriosis. Very exhaustive forms we need to fill by my staff, which is 16 pages, which involves everything, including which utensils they use, what are their habits, for their diet, whether they smoke, whether they not, and blah, blah. But also a 8 pages questionnaire filled by me also as a clinician, whereby I need to put on each and everything very, very carefully as a marker in that particular form to understand whether it really has that particular thing. We are also collecting the samples of the patient as well as the control group. The controls are again very, very selectively selected. The same age group, same area, rather same cities. If the patient comes from Gulbarga, I take the sample of control from Gulbarga patient only to have a very understanding of that particular disease more elaborately. And then we collect that sample and send it to the ICMR, where they are working on that, on the certain genetic isolation to find out whether any particular genes are involved in Indian women for this particular study or what. Friends, I'm looking forward for this particular study outcomes, because that will be something very interesting as well. I have spoken on the endometriosis a lot on various platforms, maybe the MOGS or maybe the Jaipur keynote. I always remember because which was very well taken when we compare this medical versus surgical management of endometriosis. But when I received today's topic, I was more happy, Anjali, because it gave me more insight to study a lot. Yesterday, I was sitting almost for 4 hours to understand myself certain things, rather recalling my old actually knowledge, whatever I studied in my old days. But still, I don't have answers for certain questions because we have seen that endometriosis progresses in most cases of moderate and severe disease, but there is spontaneous regression as well in 58% of the milder cases. Natural history is still uncharted to a large extent. Probably this ECGRI may put some light on that particular thing. However, the medical treatment and surgery failed to arrest disease in up to a third of the cases. Combination of the treatments have also failed to control the disease for indefinite periods when followed up. And pregnancy, we used to always say sort of treatment, but again has a variable effect on the endometriosis. Could be persistent, regression, or the progression. It can occur in the early menopause as well in association with the HRT. Because in older days, the HRT was not very commonly used and we started using it. Laparoscopic ablation of the visible endometriosis in infertile women is associated with significant increased fertility rates that we need to implement in our day-to-day practice. There's no data regarding early intervention with the prevention of this disease. I put this picture purposefully because I started my talk in Jaipur when I gave that keynote by saying Ram Ram Sa, but I can say Ram Ram Sa at the end of it. Thank you very much, friends. Thank you very much. Friends, we were actually meeting all the time on the webinars. Because of this COVID, we all knew that. And we became more actually the sentimental and more actually the understanding of the life actually per se about because of COVID. But I'm very sure now the things have changed. The physical meetings started happening, and that's why congratulations to the Solapur Vijay Society for holding these physical meetings as well, and which again becoming hybrid also, whereby the people can even log in from the outside also. Thank you very much for the opportunity. I'm always open for the questions and answers. Thank you very much.
Thank you, Milind. Whenever it is said that the etiopathologist is not known, there are many theories, and hence I think endometriosis is always said that it is a disease of theories. But
Yes.
thank you very much for taking us through the journey, its correlation with autoimmune connection and cancers, the role of estrogen, progesterone, and very recently genetics. And I feel happy when you say that Solapur is a part of ICMR study.
Thank you.
Thank you.
Sir,
Yes.
I request Velankar madam and Priyanka madam to felicitate Milind Shah sir.
That's hard, huh?
I request Jama madam, please felicitate Priyanka madam and Velankar madam.
So, Krishna.
एकच होतं तर आपल्या session मध्ये कधी होईल?
We move on to the next lecture by Dr. Bharat Jain. Now, he has done his post-graduation in radiodiagnosis and his fellowship in fetal medicine. Postgraduate from Davangere. Presently, he is working as a consultant radiologist in Beneath Hospital and consultant radiologist at Hubli. I welcome you, sir, to deliver your talk. Imaging in endometriosis.
Good morning, everyone. At the outset, I would like to thank the organizers. So I'll be talking about imaging in endometriosis. So my topic will be divided into introduction, clinical presentation, diagnosis, and imaging. So the introduction part and etiopathogenesis is well talked already by the previous speaker. So I would like to directly move on to the imaging. And with the note that I am catering all the mixed group of people. So I am going to start with the basics and keep my talks only to the simple diagnosis. So clinical presentation and clinical examination from OBG side is very important for me to make the diagnosis and look into what the imaging is actually showing. So when you say that patient is having bowel and bladder symptoms, I know that I need to look into the bowel and the bladder things as well. Otherwise, I would miss looking into it, because without a proper history and you say that there is a nodule in the region of uterosacral ligament or vaginal or pouch of Douglas, that is when I know what I need to see on imaging. So with that thing, the diagnosis actually involves, if you see, history, physical examination, imaging, and laparoscopy. So in imaging, so we usually use two modalities, that is ultrasonography and MRI. We no more use CT scan when it comes to any pelvic pathologies or especially the endometriosis. So these are the various sites. Apart from the most common site is ovaries, and then comes the pouch of Douglas. So on ultrasonography, the imaging is always and always, it starts with transabdominal sonography, followed by a transvaginal sonogram. Why transvaginal sonogram is, it gives a very good resolution. And the sensitivity on transvaginal sonography is almost far higher than the transabdominal sonography. And on transvaginal sonogram, we are able to pick, though the literature says more than 2 centimeters, even a lesion which is more than 1 centimeter, we are able to pick. So sub-centimeters lesions are very difficult to pick even on ultrasound and on MRI. So on ultrasound, they are usually cystic masses. So if you see this first ultrasound image, so that is a cystic mass with homogeneous ground glass echoes. So this is because of the recurrent hemorrhage. So the moment we see this appearance, this is classical of endometriosis. There is no differential diagnosis for this. So when you are in a doubt, see, if we see this cyst, it is a mixed echo, though there is a hypoechogenicity. And if you see at the periphery, there are hyperechoic. So what I mean by hypoechoic and hyperechoic is, hypo is something, to say in a layman's language, is black. Hyper is something which is bright or a white. So if you see, there are two bright dots here. So these are also classical signs of endometriosis. Those are nothing but the cholesterol granules. If you come to this third image, it is very heterogeneous. And if you see at the periphery where there is an arrow, you are seeing as if there is some sort of solid nodules. So that solid nodule is an endometriotic cyst where it has bled recently. So that hyperechoic thing I mean, I might raise a suspicion that there might be some solid mass over there within the cyst, but the moment I turn on my color Doppler, there is no blood flow in that region. So it makes easier for me to say that it is probably an endometriosis rather than a solid mass. And if you see this lesion, it has a ground glass attenuation and also there is a hypoechoic fluid. So this fluid is because the cyst has bled and there is a retraction of the clot. Remaining the fluid is left behind. So now coming to differentials, there are very few differential diagnoses for endometriosis. One is hemorrhagic cyst. So when we see this hemorrhagic cyst, it is hypoechoic and we see something called as lace-like pattern appearance or fishnet pattern appearance. You are seeing multiple thin septations over here and you are not seeing any ground glass appearance, nor we are seeing any cholesterol granules at the periphery. The other diagnosis of differentiation is dermoid cyst. So whenever in a dermoid, we see fat. So fat is always bright or hyperechoic on ultrasonography. So this hyperechoic thing is a fat plug. So this is a differential as a dermoid cyst. So nowadays we are using ultrasonography in deep infiltrative endometriosis also. So this is a transvaginal sonogram. If you see, this is the uterus and this is a rectum posterior to it. There is a hypoechoic nodule over here. So if I make the scan longitudinal, this is a transverse and this is a longitudinal, we can see that this is the rectum, the anal canal and the rectum, and then there is a nodule lying just in front of the rectum. So this is deep infiltrative endometriosis. So now everybody has started using transrectal ultrasound, though it is very hard for the patient to accept, but it has a major role in when it comes to the deep infiltrating endometriosis, because on transrectal ultrasonography, though the device looks very, I mean, it is a sturdy, the patient might think what is going to do with me. But then, yes, if we see this, the nodule is clearly infiltrating the serosa and all the layers of the rectum here. So this is very important when you are planning your surgeries, because you need to have a multimodality approach. You will need a gastroenterologist surgeon also. So next is, so in transrectal ultrasound, nowadays what we are doing is we are distending the rectum with jelly. So we put in around 40 ml of jelly to delineate the various layers of the rectum and see whether to what level, whether it is only infiltrating the serosa, whether it has gone to submucous layer, whether it has gone to muscularis propria, whether it has gone to mucosa. So that is still under trial, because transrectal ultrasonography is not usually accepted by our patients, first thing. And second thing is it needs a short sedation, because inserting the probe is very painful for the patient. Now coming to the ultrasound, so once you are clinically on ultrasound, we know that it is a definitive endometriosis. Then we go ahead and recheck whether our diagnosis is correct and are there any other nodules. It acts as adjuncts to the ultrasound. So I will add on to a few basics over here. So whenever we report on ultrasound, we say axial image, we say sagittal image, we say T1, we say T2, we say T1 fat sat. So what are the planes of the body? There are actually 3 planes. So one is axial. Axial is when you put a patient in an anatomic position, you are taking the slices horizontal to the patient. So that is what is axial. When it comes to sagittal, you are moving from one side of the body to the other side of the body. That is either from a right to left or left to the right. And when it comes to the coronal plane is you are moving from the front to the back, that is parallel to the axis of my body, or you are coming from back to the front. So this is how the planes are divided, and these are the different planes. So this is axial, this is sagittal, and this is coronal. So now coming to different sequences. So this is a T1 and this is T2 sequence. So I don't know what is T1. I don't know what is T2. To make it very easy, water is always white or hyper intense on T2 images. So the moment you are seeing water somewhere, for us, the best water filling organ is urinary bladder. The moment you see, sorry. Yeah. So this is the urinary bladder over here, which is hyper intense. That is, you are seeing it as a bright one. So that is T2 image. And also if you look at the endometrium, that is also bright because that has some amount of fluid in the endometrium. So this is a T2 image. And this is T1 image because I am seeing that bladder is black or it is hypo intense. So this is T1 and T2, and then we use something called as T1 fat suppressed image. So what you are basically doing is you are putting this T1, you are suppressing the fat whichever is there in the image. You are subtracting a fat from there and you are seeing that image, and that looks as T1 sagittal image over here with fat set. So I don't know where is the fat. If you see, the subcutaneous tissue is white over here. So that is how I know it is fat. And then when it comes to the T1 fat suppressed image, the subcutaneous tissue, whatever was there, is suppressed. It is black. That means we are suppressing the fat. And why it is T1? Because if I see the urinary bladder here, the urinary bladder is black. So now this is T1 without fat sat. This is T1 with fat sat image. So again, there are few more sequences which we take. So this is called a stir image. Stir image is a T2 based image because you are seeing a bladder over there. There also fat and blood both are getting suppressed. It is not just the fat, even the blood products will get suppressed on these images. We do this to see predominantly, is there any edema anywhere in the body? So now coming to the topic proper, before going to the endometriosis, we need to know most common cyst, that is the simple cyst, how it appears on MR. So this is again, I feel this is the cyst. If I tell that this is a cyst, so everybody knows that this is a bright here, it is a T2. It is black over here, that is hypo intense, and this is T1, and this is again relatively black over here, and the fat is getting suppressed. So that is T1 suppressed image because the cutaneous tissue what we are seeing is suppressed over here. Now coming to the topic of endometriosis proper, the three images which tell me it is definitive endometriosis, which gives me clear-cut diagnosis of endometriosis is T1, T1 fat sat and T2 images. Why I'm stressing so much on T1 fat sat is the differential which comes to my mind when I see bright thing on T1 is whether it is a endometriosis or is it a fat containing lesion. So to know differentiate these two, I need to suppress the background fat. So I have suppressed all the background fat which is there. The fat in the pelvis, the fat in the cutaneous tissue is all suppressed. Even after suppression, the cyst is still hyperintense, that is bright. That means there are blood products within the cyst. And if we see on, this is a T2 image because bladder is seen over here. If you see, it is not that bright as this one. There is some amount of black thing over here. If you see carefully in the below, that we called as something called as T2 shading. Because the cyst bleeds continuously, the blood products or the iron gets deposited at the lower aspect of the cyst, and that gives appearance as if there is something called as T2 shading. So this is again one more example of the endometriotic cyst. Here, the ovary is coming and sitting in the pouch of Douglas. It is in the midline, not at the adnexus. So now coming to deep infiltrating endometriosis. So here is where clinical examination and clinical inputs, the history plays a very important role. So if you take this patient, 32-year-old female, she comes with that whenever she is menstruating, there is a very bad dyspareunia and she has a difficulty in voiding. So when these two were there, we were suspecting whether somewhere in the vaginal wall, vaginal fornix or somewhere related to the bladder base or urethra will be the lesion. So if you see, these are endometriotic cysts over here. And if you see here, this is a T2 image. Again, if you see, there is some amount of black thing inside. That tells me that that is a T2 shading. And if you see here, there is a soft tissue nodule over here at the base of the bladder and posterior to the urethra. The same thing is getting confirmed on a T1 fat suppressed image here. You are seeing that is slightly bright soft tissue over there. So this was a endometriosis involving the base of the bladder. This is another case. She is 34-year female. She says that whenever I am menstruating, there is a hematuria also. So the doctor suspected that there might be something, there might be endometriotic cysts or endometriotic lesions in the urinary bladder. And if you see, there are 3 nodules, 1, 2, and 3 nodules over here. This is better visualized on T1 fat suppressed image. Everything is bright. It is in the posterior wall of the urinary bladder. So this is another case. She comes with right-sided abdominal pain. And if we see that this is the kidney, this is the ureter. The right side, there is hydroureteronephrosis and there is an abrupt cutoff of that ureter. We were probably thinking whether it is a malignancy, but then age was just 33, 34. Then we saw that there is an irregular soft tissue sitting over here that was infiltrating the uterosacral ligament on the right side and also the distal ureter, resulting in hydroureteronephrosis. So this is another case of scar endometriosis. If you see, this is a very superficial plane of the subcutaneous tissue. There is a hypoechoic nodule. The same thing is seen on MRI, that it is a hypointense nodule with small cysts inside. That means the tissue is bleeding. And that is the site of scar. So coming to the differentials on MRI, I talked about T1 and T2 again. I will be talking on T1 and T2 itself. If you see, this is T1 image, this is T2 image, because endometrium is bright over here, endometrium is black over here. And the cyst is bright on both T1 and T2. So I don't know, because there is no shading. Shading is a classical, whenever you see shading, it is for sure that it is endometriosis. So I don't know what I'm dealing with. When I do a fat suppressed image, this fat which was there on T1 images is getting suppressed here. So that means it is a dermoid cyst and not endometriosis. So this is a simple chart which depicts whatever I have spoken till now, how to differentiate the various cysts. So T1 image, something is black on bright on T2 image. If it is black on T1 and bright on T2, the diagnosis is straightforward. It's a simple cyst. If you take the hemorrhagic cyst, it is bright on all the sequences. If you take endometrioma, as I said, on T, it is bright on T1 and T1 fat suppressed. But if you see T2 image, there is some sort of shading. And this is a dermoid again. And this is a cystic neoplasm where I am seeing a peripherally enhancing nodule, solid nodule. So to come to a conclusion, though there is a lots of clinical heterogeneity and pelvic endometriosis remains challenging to diagnose, with advent of ultrasound and MRI, we are able to give a roadmap to the surgeon in majority of the cases. And also it helps in counseling the patient because she needs to understand where exactly the disease is. Because you operate an endometriotic cyst, you go in and you feel that there is a endometriotic nodule sitting just on the rectum, anterior wall of the rectum. So that changes your management also. Thank you.
Hello. Thank you so much, sir. Dr. Bharat Jain, you have enlightened us on the difficult topic of diagnosis of endometriosis. You have demonstrated the classical signs of endometriosis and the use of transrectal ultrasound and the importance of MRI in the diagnosis of the site of endometriosis. Thank you so much, sir.
Yeah, I mean, ma'am, I would like to add one word. For me to be a good radiologist or make a better diagnosis from a patient's perspective, I need a very good clinician and an examiner who is suspecting what they are seeing actually on a clinical ground. So please, a request is don't just send endometriosis query as a request letter. Please fill in something, write in something, what exactly, where exactly you are suspecting. If you tell me the patient has bowel and bladder, I know, yes, I need to look into all the surrounding structure, not just the ovaries and the fallopian tubes. Though I'll be seeing 1 centimeter nodule might be missed from my end. So we really need a very good clinical input for us to make a better diagnosis and help a patient in management.
Yes, definitely. There, their take-home message that instead of while sending a patient for an MRI or an ultrasound, we should, since it is a multi-organ associated with many organs and involving many organs, whatever symptoms the patient has, they should be actually written in the requisition form so that the radiologist can actually concentrate on the site of the mass or whatever pathology is there. Okay, thank you so much, sir.
Yes, sir. Sir, if there is a, yeah, sir, what we actually see on MR is the patient will come with neuropathic pain for sure. The moment you are diagnosing on a nerve, so it is most predominantly lumbosacral plexus is which is involved. So if the moment you say that patient is having severe nerve related problem, I will instruct my technician to please, along with routine sequence, whatever you are taking, do a sequence for lumbosacral plexus alone. Though it is very difficult for me to pick, sir, it is very easy to say theoretically that we can see everything on MRI, but it is very difficult to pick. If the nodule is more than 1.5 centimeter and it is affecting a nerve, it is easy to. So contrast imaging, most of the cases for us are straightforward. So when there is a dilemma, especially when it involves the mucosa of the rectum, so whether we are dealing with CA and rectum or it is an endometriotic nodule. So in that case, what we do is nowadays, what we do is not just a normal contrast, we do something called as dynamic contrast, because any cancer cell will have a neoangiogenesis. So it will have a high blood supply and high venous supply. It will enhance in the venous phase and wash out quickly. It will enhance in the arterial phase and wash out quickly in the venous phase. But when it comes to endometrium, the enhancement is very minimal, and even if it is enhancing, it keeps enhancing. The enhancement pattern keeps staying even in the venous phase or even in the delayed phases. So we do something called as dynamic contrast. Like similarly, what we do in pituitary gland to see whether microadenoma is there or not, the same dynamic contrast we do even in rectal cancers if suspected.
Thank you, sir. I request our chairpersons to please felicitate Dr. Bharat Jain, sir. I request Jamma madam to please felicitate.
Now we move on to our next topic, surgical management of endometriosis. Here we have for this topic Dr. Shweta Raje. She is MD, DNB, and diploma in gynecological endoscopy. She is an gynecological endoscopic surgeon at Women's Hospital, Mumbai, a premier laparoscopy institute and world's first 3D laparoscopy center. She has achieved first rank in the university in MD. She has many research publications in international journals. She has given various surgical demonstrations, delivered lectures, and presented research papers in national and international conferences. She is a national faculty at IIMA AST and has trained many gynecologists in the field of laparoscopy and hysteroscopy. She is an organizing secretary for 10 national gynecological endoscopy conferences. Her special interests are hysterectomy for large fibroids, large myomectomies, and training in gynecological endoscopy. I request you to start the topic.
Thank you very much. And thank you so much, Solapur OBGY Society, for having me here. It's always pride and joy to come here and, share with all my teachers and my friends. And the pleasure is entirely mine. I'm going to talk today about endometriosis and the surgical management or surgical strategies. Now, endometriosis is no more limited to just ovarian endometriomas. We have seen that the general incidence is rising and almost 10% women have endometriosis now. And in India, more than 26 million women are suffering from endometriosis, out of which almost 20 to 50% present with infertility. The objective of the treatment, be it medical treatment or surgical treatment, is basically management of pelvic pain and management of infertility. These are the two things that we have to treat when we are treating endometriosis. The three phenotypes of pelvic endometriosis are well known. One is superficial, which is peritoneal endometriosis. Second is ovarian endometriomas, OMAs, which are the most common. And the deep infiltrating endometriosis, which involves more than 5 millimeters of the depth, and it is the most aggressive form of endometriosis. These are the routine peritoneal lesions that we see, either the brown lesions. We don't go in expecting endometriosis, but these just come across and we can identify them as brown lesions or scarring or the white vesicular lesions, very pathognomonic. Also, we can sometimes see the peritoneal retraction windows, which are called as Allen Masters windows, and they are also very routinely seen on laparoscopy for infertility or some other reason. These peritoneal superficial lesions, either we desiccate or you fulgurate or you excise. Never leave them because they're going to grow further and form deep infiltrating endometriosis. So here, a small nodule also, if you come across, it's good to excise or fulgurate that lesion. Sometimes even on ovary, we see superficial endometriosis, not always an endometrioma. So if we come across a superficial endometriosis, don't just give wash and come out. Document that, because then it will invaginate at one point into the peritoneum and form deep endometriosis, or it will invaginate inside and form an ovarian endometrioma. So fulgurate this lesion, never to leave any endometriotic lesion alone. They are bound to grow till the age of menopause. The next common thing that we come across is the ovarian endometrioma. In fact, the most common thing is ovarian endometriomas. The patients usually present with endometriomas for managed surgical management. The dilemma here is between the ovarian cyst and infertility. We know that the ovarian cyst is also impacting fertility, and if we do a surgery, the surgery is also going to impact the fertility of the patient. So when it comes to management of ovarian endometriomas, the most controversial thing is, number one, should you do a conservative treatment or surgical treatment? There are a lot of protocols now, but many a times it boils down to a simple clinical judgment. Of course, there are guidelines. Open versus laparoscopy is a long lost debate now. Laparoscopy it is always. And drainage or coagulation versus cyst excision. Now that remains still a big controversy. So when you're treating surgically the endometrioma, number one is, should you be doing the surgery? Number two is, what kind of surgery you should be doing? Just drain or ablate or excise. So basically, to understand that, we have to know what is the impact of cyst. Why can't you leave all the cyst inside and just keep treating them medically? Because the presence of cyst also can cause mechanical stretching, reduction, pool of the primordial follicles, infections, adhesions, follicular fluid contamination, which reduces the fertility. And of course, there's a risk of malignancy. But having said that, if you operate every patient, you're going to have reduced AMH, reduced ovarian volume, reduced antral follicular count. The only thing that is maintained is vascularity, but the fertility of the patient is going to definitely drop. The AMH reduction, actually there are two reductions. See, if you compare endometriotic versus non-endometriotic cysts, in the non-endometriotic cysts, the follicular excision or healthy ovarian tissue excision is 6%. If you excise the endometriotic cyst, you are taking out 56% of the healthy ovarian tissue. Also, if you do, if you do a bilateral excision, the AMH is going to drop by 60%. Compared to unilateral endometriotic cyst excision, where the AMH will drop by 30%. Now, the woman has come to you wanting pregnancy. If she needs surgery, we have to counsel the patient regarding the drop in the AMH, because she may go for fertility to some other person. And then if the counseling is not done, the patient can have grievances about why the surgery was done. So significant AMH reduction. So surgery is a double-edged sword when it comes to endometriosis. It does reduce AMH, AFC, ovarian volume. It can cause scarring and it can affect the IVF outcome. Having said that, the surgery also reduces recurrence, increases spontaneous conception, and gives symptomatic relief, which is also equally important. The patient is not just a fertility patient. She's also a person who's suffering from pain. So basically the dilemma is to touch or not to touch. So where should you remove and where should you not remove? Do not remove endometriomas in a woman who wants fertility if she has bilateral cyst, if she has history of past surgery. The previous surgery actually reduces the ovarian function and volume significantly. So recurrent surgeries are not advisable. And the ovarian AMH reduction, if it is there, it is preferable not to pose this patient for surgery. The exceptions are pain. If the patient is extremely symptomatic, if there is bilateral hydrosalpinx, if there are large endometriomas, if it's a 9 centimeter endometrioma, even if the AMH is low, the patient still deserves a surgery. And if for IVF there's difficult access to the follicles with frozen pelvis, you still have to undertake the patient for surgery. 3 types of management: drainage and aspiration. It is not very recommended because of one, risk of recurrence, and second, risk of ovarian abscess. The second one is getting more popularity, CO2, bipolar or plasma jet ablation. The plasma jet ablation actually is a very good treatment, but I think just 1 or 2 centers in India will have a plasma jet. And the third one is cyst excision, which is still the gold standard for treatment of endometriotic cyst. This is a very interesting diagram. This is non-excisional surgery. You're just treating the obvious lesion. The excisional surgery is like a trowel. You're actually treating the root cause. So the excisional surgery has a more favorable outcome with regards to recurrence of endometrioma, recurrence of symptoms, and subsequent spontaneous pregnancy. Of course, we know that it is going to drop the AMH a little bit. So how can you reduce that impact of on the fertility? You use good technique. The first surgery has to be the best surgery. That should be in our mind ingrained always. Careful tissue handling and minimum use of diathermy. What are the surgical steps? Explore adhesiolysis, cyst rupture and drainage, dissection of endometrioma, hemostasis and reconstruction of ovary, explore the fossa, tissue retrieval, and always put an adhesion barrier like intercede so that the patient does not form adhesions again and form a frozen pelvis again. So a short film of bilateral large endometriotic cyst. Now, this patient, of course, is for fertility. Not always you can, remove the endometrioma from the point of invagination, but try to rupture it from the point of invagination. Excise the cyst wall. Here, the same thing is followed on the other side. Drain it, excise it, remove the rectal adhesions because the kissing ovaries also attract the sigmoid and the rectum. We can always differentiate the cyst wall from the healthy ovarian tissue very well because it is always stained, yellow, greenish stained. And instead of desiccating those bleeders, it is good to just take 1 or 2 sutures on the ovary because then you're not using diathermy. Never use diathermy around the hilum of the ovary also. It is good to take 1 or 2 sutures. With the pressure, the bleeding stops eventually. And we can always cover it with Intercede. We recommend and we always use Intercede for or surgical management of anything in infertile patients, be it fibroids, be it adenomyoma, be it endometriosis. If you don't, there is sometimes when it's a very large cyst, we do a direct trocar entry into the cyst and we don't allow any spillage of the chocolate material inside the peritoneal cavity. It becomes very easy when the field is clear. Adhesivolysis is always done from the ovarian fossa by sharp dissection or blunt dissection. The cyst wall is excised. And once you're in the correct plane, there is hardly any bleeding and there is hardly any struggle. And these little bleeders, we don't worry about them. Just 1 or 2 sutures on the ovaries, which are hemostatic, which are approximating, just take them and the hemostasis will happen. And we retrieve the cyst wall in an endo bag, just to avoid retrieving it directly through the trocar, because that can lead to endometriosis at the port site. So good idea is to just put it in a plastic endo bag. You don't need to do a contained tissue extraction. A plastic endo bag retrieval is good enough. Sometimes you come across very bad surprises. So this patient had high CA125 levels, wanted fertility, but when we went inside, it was a very odd picture and it was an endometrial stromal sarcoma. We just went ahead, took 1 or 2 biopsies and came out. So that's why the role of good imaging is also very important. Of course, this is a little old video. So nowadays the imaging is extremely sophisticated. Coming to the deep infiltrating endometriosis, we know that endometriomas now, just to summarize, only if it's important to get the patient conceived, we operate. Otherwise, we can manage it very well medically. But that's not the case with deep infiltrating endometriosis. These patients are always symptomatic. The peritoneal infiltration is more than 5 millimeters. It could be rectovaginal, uterosacral, bowel, bladder, ureter, vaginal, anywhere you name it, and you'll find endometriosis. Thoracic endometriosis, commonest is GI tract, urinary tract, scar endometriosis, vaginal endometriosis. Thoracic is very rare. To understand that, we also have to understand the invagination. We always see that the left side of the pelvis will have more, hemipelvis will have more endometriotic deposits because of the flow of the peritoneal fluid or the invagination in the particular area. There are 2 types of surgical approaches for endometriosis, DIE, either disease-based or symptom-based. Actually, there is a 3rd type, which is called as surgeon-based, okay, which is something we should not be following. It is either that I will not operate, I will only do ablation, I will only do conservative surgery, or I will treat it like cancer. And we see a lot of people are now just treating it like cancer, which is extremely unfair to the patient. So sticking to any one of these is actually unfair. We have to keep on modifying our technique to give the best to the patient. The disease-based approach is basically you map the disease, see how strong the disease is or grade the disease, and then plan your course of action. So this is the hashtag Enzian classification. It can, document the disease on peritoneum, ovary, tube, rectovaginal, pelvic side walls, and also adenomyosis. And, that way you can map the disease and you can then decide upon what kind of surgery. The second one is the latest AHL classification, which also decides the level of surgical complexity. In fact, this AHL classification has an app. You can just download the app, and based on your mapping, the imaging, you can put the details on the app and it will give you a score of complexity like A, B, C, D. A will be just the excision of superficial implants, and D would include actually the resection, reanastomosis of the bowel. So we can actually, decide about the extent of the surgery based on the disease. So that is disease-based approach. The second one is symptom-guided approach. It is basically primarily to focus on relief from the symptoms of pelvic pain. It involves conservative surgery, not a radical surgery, followed by post-op medical treatment. It has low morbidity, good pain relief, improve digestive function, and less complications compared to the extensive surgery. So the symptom-based approach will basically take two symptoms, obstructive symptoms and pain score. So based on the obstructive symptoms and pain score, you can decide whether to give a clinical treatment, medical treatment, or a surgical treatment. And in the surgical treatment, whether you should just do a superficial excision or an extensive excision. So this is rectovaginal endometriosis, where the rectal adhesions happen, abnormal angulation, pain during defecation, and also dyspareunia. Bowel endometriosis can also give similar symptoms, and a frozen pelvis also can give similar symptoms, where sometimes the appendix and more bowel is also involved. Bladder endometriosis, you can see here a cystoscopic view of bladder endometriosis and papillary projections inside the bladder. These can give you cyclical hematuria and severe pain during urination. And recently we are seeing a lot of scar endometriosis, where umbilical nodule, which bleeds cyclically every month and extremely painful, or endometriosis at the episiotomy site. So these are the scar endometriosis which need to be treated by wide excision. What are the objectives of surgery for deep infiltrating endometriosis? It's basically to reduce pain, GI symptoms, urinary symptoms, improving QOL. That's the main thing about these surgeries: fertility enhancement, anatomical restoration, while preserving the neurological function. We need a multidisciplinary team with you as a center, a good radiologist, a good urologist, a colorectal surgeon, and somebody with reproductive medicine facilities. So all the team will involve. So for bowel endometriosis, if it's less than 7 millimeter deep, we can just do a shaving. If it is more than 7 millimeter deep, but a small lesion, we can do a discoid excision of that lesion. And a larger than that lesion requires a resection and reanastomosis in conjunction with a colorectal surgeon. The surgical steps are SOPs. They are very standardized. You survey it, mobilize the ovaries and uterus, ureterolysis, dissection of spaces, and then go ahead and excise the endometriosis. Ovarian suspension helps in giving you space. Also, the sigmoid mobilization helps you in creating a lot of field for surgical treatment for endometriosis. So we use routinely now T-lift to lift the uterus or the ovary, so that you can suspend it without having to use an extra port for suspension of the uterus and ovaries. This is the T-lift device. It's a little plastic thread which you can use to lift the ovaries or lift the uterus. And the pararectal dissection is always started at the promontory, and you go down towards the pelvis and mobilize the rectosigmoid, mobilize the uterus, mobilize the ovaries, so that you can get a clear field. Next comes the dissection of spaces. The most important space where you work in is the Okabayashi space, which is the pararectal space on the medial side. The pararectal space is divided by the ureter into a lateral Ladskos fossa and Okabayashi space. This is the space where you do the pararectal dissection, taking care not to damage the nerves, because the nerves in this area will be the inferior hypogastric plexus, which is a combination of sympathetic and parasympathetic. The hypogastric nerve as well as pelvic flanking plexus. If you damage that, then the patient will have more bowel and bladder problems than she started with initially. There's another small trick sometimes we use. Instead of so much dissection, we just put a myoma spiral and lift the uterus up, and that helps in making all the endometriosis fall down. So this is a technique of blunt dissection to help all the endometriosis fall down. I'll just quickly show a couple of videos of rectovaginal and bladder endometriosis. These are very small films, but please feel free to tell me if I'm exceeding my time. So this is rectovaginal endometriosis. After hysterectomy, you can see a lot of fibrosis over the rectum. The patient had rectal symptoms. what you have to do is excise all the fibrotic tissue, taking care that, you're staying superficial, you're not going towards the muscularis or mucosa. It's a very superficial dissection. You can make out the fibrotic tissue separate from the supple tissue of the rectum. And in the end, you can see that all the rectum is cleared of the fibrotic tissue. The patient gets good relief, and plus it stops the progression of the disease also, because this patient is still having her ovaries. The endometriosis can invaginate and become deep. This is also another vaginal nodule, which is just right sitting on the top of the rectum. The patient had severe deep dyspareunia. So even after hysterectomy, the symptom is not going to go away because the rectovaginal nodule is still there. The patient will still have deep dyspareunia even after you do a hysterectomy for menorrhagia. So here the nodule has to be excised. And for that, we need a good MRI or a good ultrasound, because we need to map the extent. If this nodule had involved the muscularis or mucosa, then this would have been an even major surgery. But here, since the nodule did not involve any of the rectal tissue, you can superficially excise the rectal tissue, the endometriotic tissue, and you can see a soft, supple rectum right underneath this. So these are basically symptom-guided approaches. If you don't treat them, the patient is not going to be happy after the surgery because she still has pain, she still has dyspareunia. So one has to take care of to excise all the endometriosis that is there. This is a very interesting technique, and I want to share this. This is called as retrograde hysterectomy. Many times when we do hysterectomy, we see that the rectal adhesions are almost coming up to the fundus. And we just spend too much time dissecting those adhesions, and then sometimes it leads to a bowel injury or something. So here the rectal adhesions are always rectosigmoid adhesions are already coming up to the fundus. When you can't approach the posterior fossa, when the pelvis is frozen, what we do is we go anteriorly and we start the hysterectomy. We actually open the vaginal vault also anteriorly. And when you open the vaginal vault anteriorly, what happens is you can see the cervix. You lift the cervix up and shave the disease close to the cervix. When you shave very close to the cervix, the entire, I think we'll come to that in a minute, the entire bowel starts falling down. So you don't have to dissect from top to down. You dissect from down to top. From the cervix os to the fundus, you go retrograde, and it's a very easy way to do a hysterectomy in cases with frozen pelvis. You can see here from below, we are now gradually going up towards the fundus. And because you're so close to the cervix doing this, there's never any risk of damaging the rectosigmoid, because there's always a plane between the cervix and the sigmoid. If you stay flush, you will not damage any structures. The urinary tract DI has different surgical strategies. It's basically cystoscopy, dissect the spaces, ureterolysis, bladder adhesiolysis, and excision of the lesion. So this is bladder endometriosis. We can see here the invagination of endometriosis into the bladder. And we can see on cystoscopy, there's a huge growth in the bladder. Now, these patients need a symptomatic relief. We can't treat this medically. There is no role of medical management when bladder endometriosis or such large lesions are concerned. So dissection. So always first mobilization, dissection, and creation of spaces. That's the most important thing in DI. Once you create the spaces, once the bladder is mobilized, you can excise this lesion. And the lesion has to be excised widely because the microscopic endometriosis will always be there a little around the lesions. So good wide excision and suturing. We always, of course, we need the help of a urologist. But basically what we have seen is urologists are not as comfortable suturing laparoscopically as gynecologists are. So it has to be a urologist and a gynecologist team who does the surgery. They can guide you, they can do their work, and we do our work. Ureteric endometriosis is of two types, either extrinsic or intrinsic. If it is intrinsic, it is not our management. It is basically a urological management. But here, if it's an extrinsic endometriosis, that means the uterosacral endometriosis or the obliterated POD is actually kinking the ureter at one point. And if you can see here, there's a huge dilated megaureter. So this type of picture will never get treated by doing any medical treatment or just a simple adhesiolysis. Here, it actually needs the dissection and resection of the endometriosis, which is kinking the ureter at a particular point. So here we can see that the megaureter is there up to a certain level, and then it is all surrounded by fibrotic nodule and a fibrotic endometriotic area. Once we dissect it out, it is cleared up, and then the ureter goes back to its normal shape. And within a couple of minutes, the ureter gets drained and the megaureter is relieved. Having said that, if this is an intrinsic intrinsic disease of the ureter, then it might require a resection of the ureter and a laparoscopic or open ureteroneocystostomy. I think this is the last video. We will quickly have a look at that. So if the distal part of the ureter is completely affected, then we can't do a resection and re-anastomosis. In that case, the ureter has to be implanted directly onto the bladder so that we bypass that endometriotic nodule around the ureter. The process is similar to how we do the tubotubal anastomosis. So taking stay sutures, putting in the ureteric stent. This is very rarely required when a long length of ureter is lost to endometriosis, and we know that just a resection of endometriotic tissue will not clear up the obstruction. After a re-anastomosis or neocystostomy, if there's too much traction on the bladder, then we sometimes do a psoas hitch to relieve the traction on the anastomosis. So what are the goals and outcomes of DI treatment? One is to reduce pain, reduce GI symptoms, reduce urinary symptoms. There's hardly any role of medical management in this. It improves the QOL, leads to fertility enhancement, anatomical restoration, and we have to preserve the neurological function at all costs. To recap the key points, we need a meticulous and multidisciplinary planning in DI surgeries. It should be a symptom-dependent treatment, okay? And never a doctor-dependent treatment that, you know, I have learned everything and I'm going to do a carcinologic resection. That's not a good way to go about. Avoid nerve damage, nerve sparing, spare the blood supply to the ureter. We know that in the abdomen, the ureteric blood supply comes from the medial side, and in the pelvis, it comes from the lateral side. So we have to keep that in mind when dissecting the ureter. If no plane, follow the vessels. Vessels will always have plane. There is never a fibrosis around the vessel. And good hemostasis are the key point. Treatment of endometriosis should be problem-oriented and not lesion-oriented. It has to give a symptomatic relief to the patient. And just to share a few highlights of the recent ESHRE guidelines, which came out in March 2022. They say laparoscopy is no longer a diagnostic gold standard, which it was previously. CA-125 is no longer recommended as a diagnostic biomarker. Medical treatment which are no longer recommended are danazol, antiprogestrogens, and ultra-long GnRH. Surgical treatments which we no longer use is LUNA and presacral neurectomy. Pre-operative medical treatment not recommended, and post-operative treatment is useful to prevent the recurrence. We have to always remember that. Thank you so much.
Thank you, Shweta, for your excellent talk on surgical strategies of managing the endometriosis, right from whether to operate or not to operate, yes, the pros and cons, the controversies. The first surgery is supposed to be the best surgery for the patient's point of view. Your steps on retrograde hysterectomy and removal of the cyst in an endobag so that there are no recurrences, and the standard operating protocols for surgery.
Thank you, madam. Yes, sir.
Hello.
Operative medical treatment. So I just wanted to know whether during endometrioma, surgery for endometrioma, would you pre-operatively give GNRH analog and then operate so that you could get a good plane during cystectomy?
So if the patient needs a surgical treatment, we straight away, if it's a large endometrioma, say 8 centimeter, 9 centimeter, we straight away pose them for surgery, then don't give any preoperative medical treatment. If the patient is not for surgery, then we mostly refer her, start her on medical treatment. Then don't consider the surgical treatment at all. And we always counsel the patient, if we are doing the surgical treatment, that it's going to drop the AMH significantly. So for endometrioma and infertility, we try to avoid doing the surgery unless the patient at least has the egg freezing done. So we don't give routine preoperative medical treatment before surgery.
So the direct question is, would GNRH analog help you get the plane during
No,
cystectomy?
it wouldn't, because the planes of endometriotic cyst are very clearly, separated. Whether you give pre-op GNRH or whether you don't, you always find a good plane, and it separates very softly and smoothly from the ovarian tissue, unless it is a recurrent surgery. In the second surgery, you find it difficult to get planes.
You mentioned, we are unaware of what you mentioned about plasma
jet.
Yeah, can you just highlight?
So plasma jet is a recent treatment like CO2 ablation, which can ablate the endometriotic cyst wall up to less than a millimeter also. So when we excise, we say that the cyst wall is gone. Okay, and when we don't excise, we say that there is a very high risk of recurrence. So this is somewhere in between. The CO2 laser and plasma jet will ablate the wall, so it prevents the recurrence of the cyst. But we are not removing the cyst, so we are not actually damaging the ovary in any way. So it's coming up in a very big way, but there are hardly any centers in India. I think Dr. Hafiz has plasma jet, and I don't know anybody who has a plasma jet in life. So to advocate that is just because it's a good technology. We don't have the instrumentation for that, but maybe it will come a lot more. So I think Europe, they have started using a lot of plasma jet treatments now. So it's just ablating the surface with that tiny probe.
Okay, thank you for that. And it's actually too late for the people here to know that you mentioned about gynecologists having association with the urologist. Only one person from our society realized that long back, and she got associated with the urologist.
Yes. We can have friends as urologists. No? It doesn't have to be a spouse. Thank you so much.
Thank you, Shweta.
Thank you.
We move on to the next talk.
Excuse me. I request our chairpersons and Anjali Jamma madam to please felicitate Shweta Raja madam.
There is a slight change in the program. We move on to the next lecture, that is endometriosis and infertility by Dr. Manjari Vasankar. Dr. Manjari Vasankar has done a fellowship in minimally invasive gynecology. She is the director and consultant at Bhide Hospital Test Tube Baby Center in Pune. She is a clinical secretary of Pune Obstetric Gynec Society and a life member of ISAR. I welcome Dr. Manjari Vasankar.
Thank you, madam. At the outset, let me thank Dr. Anjali Jamma madam and team SOGS for inviting me as a speaker today. I'm Dr. Manjiri Varsankar. I'm an IVF consultant in Pune, and I will be speaking about endometriosis and infertility. So today we shall see sites of endometriosis and its impact on fertility, clinical scenarios in endometriosis, medical versus surgical management of endometriomas, IUI in endometriosis, IVF in endometriosis, and strategies to optimize results in endometriosis fertility practices. So why endometriosis affects fertility in the first place? We all are aware that there is a very delicate balance between the pro-inflammatory and the anti-inflammatory cytokines. And endometriosis per se by the retrograde menstruation hampers this particular delicate balance, resulting as a result of which the pro-inflammatory cytokines like the interleukin-1, TNF-alpha, autoantibodies, macrophages, TREG cells, which are especially the new kids on the block, and there is also a genetic or rather an epigenetic origin of the endometriosis because of the FCLL3 and the HOXA10 homeostasis. So all in all, this pro-inflammatory disorder results in increased angiogenesis, increase in the cell replication outside the endometrium, and thereby decreases the germ cell apoptosis. So to simplify my talk, I'm going to keep it extremely practical. So this is a 28-year-old lady who was referred to me for infertility, active married life 4 years, previous 2 IUI failures with only mild dysmenorrhea. Sonography of pelvis was absolutely normal. Her AMH was 1.8, antral follicular count on the second day was 7, thyroid prolactin normal, HSG showed bilateral patent tubes, all the semen parameters were normal. What next? We have so many patients who walk to our OPDs day in and day out with these kind of histories. And will we do scopy for all the dysmenorias? Now she's failed 2 IUIs, which was with oral ovulagens. So will I again do one more IUI? If yes, will it be with oral ovulagen, or will I like to add back a gonadotropin therapy? And is there any role for medical ovarian suppression using OC pills, Dynogest, or GnRH agonist? So as a matter of a rule, every infertility patient, I always do a transvaginal ultrasound with the sliding sign. Now, this sliding sign is an extremely important clinical diagnostic tool. Whenever you're putting a TV probe inside, slide your probe anteriorly onto the fornix. Similarly, posteriorly do that. If you have a tenderness or wincing, sometimes even you might find nodular palpations on your transvaginal probe, it is a definite sign that there has to be a raised index of suspicion for endometriosis, irrespective of whether she has symptoms or she does not have symptoms. So this patient, because she had a sliding sign, we decided to evaluate her further. Now, we always do ovarian reserve assessment strategies, which includes mainly AMH and AFC, which are the predictive markers for an ovarian reserve of a patient of any age. Previous response, so she had been stimulated previously with 2 cycles of clomiphene and letrozole. Gonadotropins were not used, but the patient had ovulated as per the previous physician's folliculometry reports and the age and BMI. As per the history and as per the available reports, we repeated the AFC and the AMH, and the AMH was 1.8 and AFC is 7. So now we have a patient who has only mild dysmenorrhea. My sliding sign is positive, but she is a good responder patient as per her ovarian reserve markers. So I put in a scope because I had a high index of suspicion because of the sliding sign. And this was what I saw, just minor powder burn appearances in the POD as well as the lateral wall. And Dr. Shweta has excellently, it was an extremely lucid lecture, Shweta, and it was so comprehensive. So I'm not going to talk anything about the operative part of laparoscopy. But if we understand, it is very important when to advise laparoscopy in fertility endometriosis. And as for the key practice points from the Indian perspective published in 2015, laparoscopy has to be combined with histopathology for diagnosing endometriosis. It is recommended for diagnosis. However, a negative histology does not still exclude it, and clinicians should obtain tissue for histology in women undergoing surgery for any ovarian endometrioma or DIE, especially to exclude rare instances of malignancy. So this is the NZIAN and the ASRM combined classification. You yourself can, it's so confusing. It's really very confusing. But at the end of it, when you do a laparoscopy, we have to, in a nutshell, classify our patient whether she is having a superficial peritoneal disease, that is stage 1, whether she has an ovarian superficial disease or a deep disease, that is stage 2, 3, and DIE, which is very severe endometriosis. So now this patient of mine, we classified her as a stage 1-2 disease from history, laparoscopy, sliding sign positive, but her ovarian markers are suggesting that she has a good ovarian reserve because her antral follicular count and her AMH are still on the better side of normal. So this is something which every IVF physician must know. This is known as the endometriosis fertility index. Adamson and Pasta have published this in 2010, and it is an excellent clinical tool to predict the pregnancy rates in patients with confirmed endometriosis, and it predicts the probability of a conception. So if your EFI score is between 0 to 3, the chances of conception are as dismal as 10%. If it is between 4 to 8, 10 to 70%. If it is 9 to 10 and above, you have a good chance of conception, just like your non-endometriosis counterparts. This is very useful, especially when you're counseling the endometriosis patients for fertility management, because we need to give them realistic values and not just say that my success rate is 70% and 80% and so on and so forth. So this is the endometriosis fertility index chart, which includes 2 factors. To the left is the historical factor, which will include history, that is age, years of infertility, and previous pregnancy failing. To the right, we have surgical factors, which is the AFS endometriosis scoring, and hence EFI is nothing but a combination of historical and surgical factors, which gives a comprehensive value. So now that I have diagnosed my patient as stage 1-2 endometriosis, as per the Endometriosis Lancet review, if you have a stage 1, stage 2 disease clinically and with laparoscopy, if a patient is less than 35 years with a good ovarian reserve, you can go ahead with expectant management or COH with IUI. If your patient is an elderly patient with age more than 35 years and poor ovarian reserve markers, we need to directly step up for IVF irrespective of other parameters. So now I decided the patient that I will give her one more good try of IUI, because in the first 2 cycles gonadotropins were not used. I decided to use a combined approach with oral ovulations and gonadotropins. So what are the ways in which COH and endometriosis can be done? First line, always CC or letrozole. Of course, in Indian scenario, it depends very much on the affordability of our patients as well. Second line, gonadotropins, and the third line, IVF. Clomiphene or letrozole can be combined as an add-back gonadotropin therapy to increase the cumulative pregnancy rates. So we can use gonadotropins add back as a step-up protocol or a step-down protocol. We know that step-up protocol has given increased live birth rates and ongoing pregnancy rates, and hence that was my protocol of choice. It can be done in 2 ways, either the sequential gonadotropin regimen or the conjunctional gonadotropin regimen. At any given point of time, if you are seeing 4 follicles or more on your sono monitoring, please convert this patient to IVF, because otherwise you're going to end up decreasing her ovarian reserve by not doing anything substantial. Sometimes, or many a times in endometriosis patients, if there is absolutely no follicle till your 2 weeks of stimulation, cancel the cycle. So life is full of surprises, and even as endometriosis, and one has to expect the unexpected at any given point of time in endometriosis management. So what is this sequential regimen? First 5 days, you give clomiphene or letrozole. Starting after the finishing of your letrozole therapy, give daily dose of gonadotropins. If your patient is affordable, you can give a recombinant FSH. If she's not affordable, give HMG 75. Now, if your patient is having a very high BMI or other factors as well, you can even start with 150 international units. So give a daily dose of gonadotropin till your lead follicle becomes 18 to 20 millimeter in size, then trigger the patient and do a single good post-ovulatory IUI. There is no role for double IUI as per statistical data. Now, if you want to go ahead with a conjunctional regimen, which is slightly a cost-effective approach, we will give 5 days of clomiphene or letrozole, and then alternate day gonadotropin therapy, again 75 or 150, depending on the BMI and other factors. You can give it as an alternate day therapy again till your lead follicle goes to 18 to 20 millimeter size, trigger the follicle, and then do a post-ovulatory good IUI. Now, are there any strategies to optimize the sono monitoring in endometriosis? So I always love to add Dopplers to all my fertility scan, irrespective of whether you have a busy practice or not, because we know that Dopplers have revolutionized the obstetric scenario, especially the decision-making in obstetrics. And it has even extrapolated to fertility practice. And now we decide when to trigger based on Dopplers only, irrespective of the size of the lead follicle. So this was day 10 of the same patient. I had a 16 millimeter single dominant follicle. The pre-ovulatory scan, again, I did on day 12, and I saw an 18 millimeter follicle by morphometric studies. When I added Doppler, it was insufficient, and I called the patient after 2 days. Now, when to trigger this patient in IUI is the million-dollar question. The trigger has to be based on Dopplers. So if your perifollicular flow is more than 3/4 or more than 75% of the diameter of that follicle, if you are lucky, you will see a cumulus opericus, which can be seen on a 3D in the second picture at 6 o'clock position. And if you're doing a spectral Doppler, your peak systolic velocity must be more than 10 centimeter per second. Your perifollicular RI should go less than 0.5, and your flow should exceed 3/4. Mind you, the Doppler settings for obstetric Dopplers are completely different from those of fertility Dopplers, and you need to get a preset for these Doppler settings from your imaging person from your machines. Now, it is very important to ascertain the endometrial synchrony apart from the perifollicular flow. So if you have a good trilaminar follicular phase endometrium, which is then proceeding nicely to a good secretory ground glass appearance with an excellent Doppler flow. So there is an Applebaum scoring for Doppler. And if you have a flow which is exceeding zone 3 or zone 4, that is zone 4 is touching the endometrial central line, then you have done your best possible effort for this particular IUI cycle. IUI in endometriosis is not a cakewalk, because as Dr. Shweta has shown, there are so many adhesions. Sometimes the uterus is pulled up, the virgin is deficient. So especially in acutely anteverted or retroverted uteri, you can do some practical tips and tricks during the IUI to prevent the hitch at internal os. So what you can do is, if it's a acutely retroverted uterus, instead of keeping the patient full bladder, just keep it half to 1/4 of the bladder. So that will ease out the access, or use a sono-guided IUI to put the catheter at ease. If it's an acutely anteverted uterus though, the bladder is not going to help you much, but you might have to pull the anterior lip of the cervix with the valsalum, straighten the axis, and then put in your IUI catheter. So this was about IUI in endometriosis. Now this is the second case, a 34-year-old lady with multiple IUI failures with AMH 1.1 and antral follicular count 4 with severe dyspareunia, normal semen parameters, bilateral patent tubes, came for fertility management. So shall I go ahead and do a laparoscopy right away now that she's failed multiple IUIs? Or is there anything which I can do? So first thing is probe the patient. So when you do a probe, this patient had not been operated in the past, and this is a primary diagnosis of a ovarian endometrioma. Now I could easily go ahead with laparoscopy now that I have diagnosed an ovarian endometrioma, possible endometrioma we may say. But what I have done now since last 2 years, since the hashtag NZN classification, is that I always refer all my endometrioma patients for a super specialist endometriosis sonologist. And is there any role of imaging in management of endometriosis? Can we stage it preoperatively based only on sonographies? So basically, we know that a bad workman blames his tools, but a good workman spends adequate time in sharpening his tools. And the best tool, which is going to give me an accurate preoperative assessment, is the transvaginal probe. So there are various sonologist who are specialized in endometriosis scanning. And you will not believe it, this is one of my friends from Hyderabad, Dr. Vimi Bindra, who's an endometriosis excision surgeon, has an extensive work, and she has published preoperative mapping and structured reporting of pelvic endometriosis lesions on dynamic ultrasound and its correlation on laparoscopy using the hashtag NZIAN classification. So this patient of mine was from Mumbai, and I chose Dr. Aniruddha Badade sir. You must be knowing Chikitsa ultrasound. He's very famous. And this is the level of reporting he does. On scanning the patient, he will give you an exact diagram of the rectovaginal involvement, including the torus nodules and the level and the staging of accurate endometriosis before you even put in a scope. So this is the report which says the involvement of the rectovaginal septum, utrovesical junctions, uterosacral ligaments, so on and so forth. So imagine my gynec laparoscopist thanking the radiologist before putting in a scope. The diagnosis is full and final and ready, and it's extremely important to counsel the patients as well. So what are the indications for surgery in endometriosis? ASHRAE 2022 guidelines, I think Dr. Kalyan sir is going to elaborate more on that. Surgery is not recommended to perform in ovarian endometrioma patient as per the endometriosis 22 ASHRAE guidelines, because they say that it does not improve the live birth. But there are other schools of thought as well, which have put forth that this endometrioma fluid is full of inflammatory cytokines like TNF-alpha, interleukin, so on and so forth. Now, the oocytes which are going to grow in this particular environment, it has been noted that they have a miserable oocyte quality as compared to the contralateral ovary where the endometrioma does not exist. So though we agree that there is decrement in the AMH post-surgery, but when we have such great laparoscopic surgeons sitting here, so we need not worry. So in my opinion, and in practical scenarios, any endometrioma more than 3 centimeters, I go ahead with excision, then followed by IVF. Though the guidelines actually say the other way around. Surgery is indicated in symptomatic endometriosis, hydrosalpinx, excessively large endometriomas for fear of puncture, and distorted anatomy, especially adhesolysis, at least must be done pre-ovum pickup to ease the access to the ovaries, and DIE is an absolute indication for surgery. So this was the patient. We scoped her and confirmed diagnosis as stage 3-4 endometriosis. Now my diagnosis was clear, and will we, this I think would answer Dr. Dabde's question, will we go ahead for a post-operative or a pre-IVF ovarian suppression? Now, it is not recommended routinely by endometriosis ASHRAE guidelines, but sir, I would completely agree with you, because in the Indian scenario, when you advise IVF to the patient, she will talk to her mother-in-law, aunties, uncles, and she will come back after at least 6 months to 1 year. So rather than not doing anything, we can at least prevent recurrence of endometriosis by giving an ovarian suppression, irrespective of what the European Society has to say, because we have to individualize our practice for our own patients. But it is not recommended routinely because it doesn't cause any increase in the live birth rates or the take-home baby rates. So extremely important, preoperative AMH has to be done, has to be documented on paper, and the patient's consent must be taken. Post-operative AMH, 3 months post-surgery, again has to be done and documented. This is very important because it can, medico-legally, it's extremely important these days, and it is better to document about the ovarian reserve post-cystectomy. So post-operative, we can give various medical analogs for ovarian suppression, and the commonest being GnRH depots, Dynogest, or Ocipil's pre-treatment. So this is a head-to-head comparison chart between all the ovarian suppression analogs. If you have to use the COCs, they can be given 6 to 8 weeks before your IVF cycle or post-operatively to regularize the cycle and prevent the recurrence. GnRH Lupride depot, you can have 2 protocols. One is the long protocol, which suggests that monthly you have to call the patient and inject her 3.75 depot or give her 11.25 depot every 3 monthly. There is another extremely interesting publication which has given better live birth rates, which is the short GnRH agonist protocol. What they have done is on day 2 of the first cycle, they have given the depot, repeated it it in the luteal phase of the same cycle and immediately started IVF stimulation in the subsequent cycle. So this has given better results as compared to the long ovarian suppression. Now the new kid on the block, Dynogest. So what is this Dynogest? Dynogest is a selective progesterone receptor modulator. So it acts on the HPO axis, that is central effects, and peripheral effects, that is on the ovary and the endometrium. So it inhibits the gonadotropin secretion, thereby resulting in a hypoestrogenic and a hypergestagenic environment. And as a result of ovarian function diminishing, it results in unovulation. On the local background on the endometrium, it has anti-proliferative, anti-inflammatory, and anti-angiogenic effects. So the beauty of Dynogest is you can start Dynogest from any day of the cycle. You need not wait for the menses. The dose is 2 milligrams per day. There have been trials with 4 and 6 milligrams as well, but 2 milligrams per day has shown an equal efficacy and potency as far as the counterparts are concerned. Extremely important take-home message of Dynogest. Once you stop giving Dynogest for your patient, please don't start the IUI or IVF cycle right away, because the ovarian activity comes back to normal 43 to 60 days after stopping Dynogest. And this is extremely important. There have been papers in which you stop the Dynogest, immediately start, you don't get a single follicle. Rather wait for 2 months, you will get an excellent follicle, you will get an excellent outcome as well. There has been significant improvement in the VAS score, that is the pain score, as well as reduction in the size of the ovarian endometriomas. And there have been studies which have proven beyond doubt that the long-term safety up to 66 days is absolutely safe in Dynogest. So when to directly step up to ART in endometriosis? If you have a stage 3-4 disease, tubal dysfunction, male factor, previous IUI failures with stage 1-2, and advanced age with low AMH. So these are the indications in which you don't have to waste time. Time is extremely important. You're running against the biological clock, and step up your treatment. Now, I decided to do IVF in this particular patient with stage 3 endometriosis, fully diagnosed and documented. This is a tug of war which has been going on since ages, agonist versus antagonist protocols. Now we know that agonist protocols are of 3 types: the long agonist protocol, the short protocol, and the ultra short protocol, while the antagonist is a single flexible or a fixed antagonist protocol. So we'll just pass through what exactly do we do in an agonist protocol. In the agonist protocol, from the day 21 of the previous cycle, we give 1 milligram per day of GnRH agonist. From the second day of this next cycle, immediately, you start giving gonadotropins depending on the age and AFC of the patient. Reduce your GnRH agonist dose by half, that is, start with 0.5 milligram per day. Continue this cycle, go till 18-20 millimeter, see your Dopplers, and trigger with HCG. It causes complete suppression of pituitary hormone, thereby causing a very coherent and a very good quality of oocytes. And it reduces the LH and androgen levels, cycle cancellation is less, and flexibility of schedule is very high. The cons, however, are it is very high cost therapy and the duration is practically almost 21 days. In the antagonist protocol, what is done is from the second day of the menses, start giving your daily dose of gonadotropins till your lead follicle is 14 millimeter in a flexible protocol. Start antagonist cetrorelix 0.25 subcutaneous, continue your gonadotropins and antagonists till your day of trigger and trigger the patient. Short duration, less dose of FSH, rapid reversibility, and lesser cyst. So, but in spite of whatever protocol, always expect the unexpected in endometriosis. It can be really challenging. And so we must be very sure about our Poseidon criteria. This Poseidon criteria came into picture after the Bologna criteria did not do so well. So in Poseidon, especially when we come in endometriosis patient, we have these young patients with a good ovarian reserve. You stimulate the patient and she gives you dhoka. She doesn't give you any good follicles, and then you keep on wondering what has happened. Similarly, these group 2 patients are already elderly with good ovarian reserve, but again, not good follicles. So especially in the next cycle, it will give you some insight into what gonadotropin, what dose, any adjustments can be done for betterment of the IVF cycles. So are there any strategies to optimize your IVF outcomes and improve them in endometriosis patient? Next slide is my favorite. I am a big fan of soft protocols. I don't go full throttle. I remain in the soft protocol region in which I give in endometriosis patients, first 5 days, give clomiphene or letrozole in your routine dose, and 2 days after starting your oral ovulations, give daily dose of HMG 150 till you have a lead follicle, which can be as low as even 1 or 2 lead follicle in severe endometriosis patients, but it tests your patience. You have to continue till the lead follicle goes to 18-19 millimeter with a good Doppler, trigger the patient. Now in MOS protocol, you have to add an antagonist when your lead follicle is 14 millimeter. So it's like an antagonist protocol, but a softer protocol. So it has been shown that you get fewer oocytes with lower estradiol levels, lesser gonadotropin ampules, but the implantation rate and pregnancy rate according to data is similar, but according to practice is much better. Now, this is something we have been following since the last 4 years. We have our own, I have my own data for my center. I have done it with my close friend, Dr. Mugdha Parasnis from KM Hospital. Now we do Diostim and Accuvate for poor ovarian reserve patients, and endometriosis is one of them. What is done? Primary stimulation, day 2 onwards, start gonadotropin, trigger first time with the help of decapeptyl, do a ovum pickup, wait for 3 days, immediately start the stimulation in the same luteal phase, again start your gonadotropin, and next time do a ovitral trigger or a HCG trigger. Why this? Because we know that as per the new research, there are 2 waves of follicular recruitment in any menstrual cycle. So we are actually encashing on the follicular phase as well as the luteal phase follicular cohort recruitment, and we get much better quality of blastocyst actually in the luteal phase just before her next menses starts. Of course, because we are doing back-to-back stimulation, all the embryos have to be pooled or rather accumulated by vitrification, and hence the name Accuvate. PRP in endometriosis has also shown extremely great results. What is done in PRP? 12 ml blood of the patient is to be taken. We have various processes like is processed. This is nothing but platelet-rich plasma, which have been extensively used in the medicine sector, isn't it? So here we are separating half ml PRP at warm centrifuge. We have our own units, but you can also get it done from the next blood banks because they do it routinely. They separate your PRPs. Now this PRP, half ml, can be injected into your ovary by transvaginal approach with a ovum pickup needle. Wait for 2 cycles, and 3rd cycle, immediately start the IVF protocol. It has also been done laparoscopically. It has been injected in the stroma and has shown similar effects, but I feel that the transvaginal injection is a daycare kind of a thing and slightly easier rather than doing a laparoscopic injection into the stroma. So this platelet-rich plasma may have great effect on the rescue of the ovarian function, especially in poor ovarian responders endometriosis patients. It helps in recovering the ovarian sex hormone, reduces the apoptosis of germ cells, and thereby increasing the number of follicles. These are the Eshere endometriosis guidelines. I can see Kalyan sir, he has a talk, so I'm escaping this slide. So endometriosis is a challenging disease and requires decision-making at each and every stage. It can range right from black-red small vesicles to a completely distorted anatomy, including the bowel endometriosis. And what needs to be done is we have to be a team. The patient and the clinician has to talk this out. We are a team into this painful journey of endometriosis, and we have a responsibility of sailing this girl through towards a successful pregnancy. There is no one-size-fits-all formula for success in endometriosis, and this is what Sachin Tendulkar, my favorite cricketer, had said in one of the reporter conference when he was asked how come he gets centuries in every matches. He said, I just keep it simple, watch the ball and play it on merit. So if we have to extrapolate his views to IVF in endometriosis, individualize each case based on its merit. Don't go by what evidence says. Our own Practice, talk to your colleagues who have done endometriosis patients, and that's the way out. So the ideal strategy is individualized controlled ovarian stimulation, which has to be a tailor-made protocol for each and every patient, depending upon the age, BMI, antral follicular count, AMH, previous hypo or hyper response. And the most important thing in endometriosis, which is to be considered, is time to pregnancy. Thank you so much for a patient listening. Thank you, SOGS. And I actually can't avoid mentioning, I am a gynecologist because of Dr. Sardesai Madam. I was a MBBS student from VM Medical College, and I took gynac. I think most of the girls in my batch took gynac looking at Madam, and I'm extremely humbled today to give a talk in front of Madam. Thank you. Last but not the least, if the organizers allow me, we have our own candidate from POGS who's contesting the Foxy President elections, none other than Dr. Sunita Tandulkar Madam. And it's my earnest request to please vote and support for her as well. Thank you.
Hello. Thank you so much, Dr. Manjari Valsankar. You have given us a lot of guidelines on the evaluation of the ovarian reserve. You had a wonderful lecture on the infertility management in various patients of endometriosis. You have also given guidelines on the indications of surgery, various modalities of ovarian stimulation protocols. You have also enlightened us on the use of vaginal ultrasound and the ovarian Dopplers. You have also given us the information about the use of medications like Dynogest and indications for ART and IVF, and protocols in IVF and progesterone supplements. You have also introduced us to new technologies like PRP. So thank you so much. I also thank our Obstetric and Gynec Society for giving us the opportunity to chair this session. Thank you so much.
I request our chairpersons and dear Jamma Madam to please felicitate Manjari Valsankar Madam.
Hello.
Thank you, everyone. Everyone, please join for the inauguration ceremony. Always have eyes that see the best, a heart that forgives the worst, a mind that forgets the bad, and a soul that never loses a hope. Just to keep hope alive in every mind, we pray, praise, and worship the God. I request all dignitaries, please come on dais for the inauguration ceremony. Our AMOGS President, Dr. Rajendra Singh Pardeshi sir is joining online. Dr. Anjali Jamma ma'am, Dr. Kalyan Barmade sir, Dr. Milind Shah sir, Dr. Shweta Raje, Dr. Manjari Valsankar, Dr. Bharat Jain, Dr. Rohini Deshpande, and Dr. Kade, and Dr. Shashikant Umbardad sir. Please join us on the stage. All office bearers of SOGS, please join for the ceremony. Oh. I request all dignitaries please come forward for lamp lighting ceremony. It's a great tribute to Goddess Saraswati. Pray for God, good health, education, and the care we give to our universe.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमो नमोस्तुते दीपज्योतिर्नमोस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छाहि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु
I request Dr. Rajendra Singh Pardeshi, sir, please address the audience.
Good afternoon, everybody. I am feeling proud and honored to be a part of this conference on endometriosis. Endometriosis not
Sir, please unmute yourself.
Good afternoon, everybody. Feeling proud and honored to be a part of this conference on endometriosis. Endometriosis not only affects fertility, but also poses many gynecological issues. I congratulate Solapur Obstetric Gynec Society and Dr. Kalyan Badamde, our infertility committee chairperson of AMOGS, who is very active and energetic chairperson, with Dr. Monica Umbardand, our chairperson of AMOGS PSC committee. Organizers, Dr. Anjali Jama, President SOGS, and Dr. Archana Khare, Secretary, and Team SOGS for organizing such an academic and practical conference on endometriosis. With the galaxy of international speakers like Dr. Mohammad Mabrok, Dr. Suruchi Pandey, Dr. Emily Gaison, and with our national faculties, Dr. Milind Shah sir, Dr. Shweta Raje, Dr. Manjiri Valsankar, Dr. Kalyan Baramde, Dr. Deshpande madam, Dr. Sandesh Kade, and all chairpersons. I think this will be going to be a great event. I wish every success to this conference. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. I request Dr. Anjali Jama, ma'am, please share her views about this conference.
Good afternoon. A warm welcome to all of you. It is my proud privilege and honor to address this August gathering. My highest regards to the esteemed guests who are with us today to share the latest trends and advancement in the treatment of endometriosis. Since working towards the elevating the agony of women, endometriosis is difficult to diagnose and diagnosed very late. So woman has to go through enormous pain and suffering, and infertility is a main concern. Lao Tzu says, do the difficult things while they are easy. Do the great things while they are small. So let us gain insight on how to detect early and treat completely this debilitating disease. Today we have a dedicated speakers dedicated themselves to upgrade their skills to improve women's health. Today we have आपल्या सोलापूरच्या सुकन्या डॉक्टर श्वेता राजे आणि मंजिरी वळसंकर ज्यांनी स्वकष्टातून यशाची पताका अशी उंचवली आहे आणि सोलापूरचं नाव रोशन केलेलं आहे. आणि आपल्या सोसायटीच्या डॉक्टर रोहिणी देशपांडे मॅडम, डॉक्टर मिलिंद शाह सर, डॉक्टर संदेश कादे, भारत जैन सर. Not only this, we have a speakers from UK, Dr. Mohammad Mabruk, a very well-known, thorough academician from Cambridge University, and Dr. Suruchi Pandey from London, and Dr. Emily Jelson, who will enlighten us on MDT. Knowledge is knowing the depth of ocean, that is endometriosis, and wisdom is knowing till where to swim, till where to treat. All the faculties are well versed with this, and we really thank you, Dr. Rajendra Singh Pardesi sir, Dr. Sujata Dalvi, Dr. Kalyan Baramdev for giving us opportunity to associate with SOGS Infertility Committee. Thank you from bottom of my heart, all speakers, seniors, teachers, and all my friends for attending this CME. Thank you very much.
Thank you, ma'am. I request Dr. Kalyan Baramdev sir, please give his blessing for the CME of endometriosis.
Esteemed Solapur Society members, SOGS President, Dr. Pardesi sir, SOGS Secretary, Dr. Sujata Dalvi ma'am, and President and Secretary of Solapur OBGYN Society. I'm so grateful to them for giving SOGS Infertility Committee to conduct this hybrid webinar come conference today on the topic of endometriosis. I hope this is going to enrich everybody with the knowledge of recent advances of endometriosis. And almost 4 speakers have talked so nicely, and the incoming speakers from across the world are going to guide us about the endometriosis and other aspects of endometriosis. So I'm really thankful to Dr. Anjali for giving SOGS this opportunity to conduct this endometriosis CME. Thank you all SOGS members and those who are attending on webinar or on Zoom platform. Thank you so much.
Thank you, sir. We are moving to the second session. For this session, I request Dr. Shitola madam and Dr. Virkar sir as a chairperson. Dr. Lalita Shitola madam, she is a consultant at Balaji Hospital, Solapur, and she is a past president of SOGS. Dr. Vivek Virkar sir, he is consultant at Virkar Hospital, presented various papers at state and national conferences and got prize for the same. He is also a good teacher. Thank you, sir. Thank you, ma'am. Over to you.
Good afternoon, everyone. At the outset, I would like to thank team for giving opportunity to chair this wonderful session. First of all, I take opportunity to introduce today's speaker, Dr. Kalyan Baramdev sir. He is the chairperson of Public Awareness Committee, FOXI. Also, he is the chairperson of Infertility Committee, SOGS. He is the joint secretary, IAGE, convener for Mission Save the Uterus, FOXI. And at present, he is the president of IMA Latur. So may I request Dr. Kalyan Baramdev to proceed with his proceedings. His topic is recent ESHRE guidelines for management of endometriosis.
Thank you, chairpersons, for this nice introduction. After the so exciting lectures, my topic is going to be a theoretical topic, morely because what 2014 guidelines were saying and what 2022 February guidelines of ISHRE are saying. As everybody knows, endometriosis is a disease with enigma, and now there are around 50% of infertile patients who have endometriosis. Around 2 to 10% of women are having endometriosis. Day to day, with the advances of laparoscopic surgery, there are so many techniques coming up with deep endometriosis surgery, LUNA, presacral neurectomy. So we are doing all these procedures. Everybody who is doing a retroperitoneal dissection is going into the endometriosis surgery. So like Dr. Shweta has shown so many nice videos. So are we really justified in doing everything? And that's what ISHRE always thinks of, doing the things in a more randomized control studies. And what we got is these RCT guidelines, which are coming as ISHRE guidelines. Endometriosis is a chronic inflammatory disease defined as presence of endometrium-like tissue outside the uterine cavity. It is found in reproductive age group, and clinical consequences of endometriosis and in management can last well into post-menopause. So why these guidelines are important? They have taken into consideration of adolescents as well as post-menopause. Although these are 2013-14 guidelines, and now coming with the February 2022 ISHRE endometriosis guideline development group. So first, we are going to see what are the changes in the current guidelines, what are the current versions which has been changed. In the diagnosis of endometriosis, underline it, laparoscopy is no longer the diagnostic gold standard, and it is only recommended in patients with negative imaging results and or where empirical treatment was unsuccessful or inappropriate. Treatment of endometriosis associated pain. Studies of GnRH antagonist treatment support their use as additional or second line treatment options. Recent data indicate that post-op medical treatment may be beneficial towards pain management and support a recommendation to offer it in women not desiring immediate pregnancy. Danazol and antiprogesterone, LUNA, presacral neurectomy, and anti-adhesion agents are no longer included in the recommendations. When you talk of treatment of endometriosis associated infertility, the extended administration of GnRH agonists prior to ART treatment to improve live birth rate in infertile women with endometriosis is no longer recommended due to unclear benefits. The endometriosis fertility index was added as a step in the treatment as it can support decision making for the most appropriate option to achieve pregnancy after the surgery. Also, they have talked about endometriosis recurrence, endometriosis and adolescence, endometriosis and menopause, and endometriosis and cancer were more extensive information as compared to 2014. So now we are going to go towards each diagnosis, each of the variants which we are talking, that is diagnosis, treatment, infertility, recurrence, and everything. So the GDG statement of signs and symptoms says, currently no evidence exists that a symptom, that is diary, questionnaire, app reduces the time to diagnose or leads to earlier diagnosis. The GDG considers their potential benefit in complementing the traditional history taking process as it aids in objecting pain and empowering women to demonstrate their symptoms. So what we recommend and what we get out of it, that clinicians should consider the diagnosis of endometriosis in individuals presenting following cyclical and non-cyclical symptoms like dyspareunia, dysmenorrhea, dysuria, dysphagia, painful rectal bleeding, or hematuria, cyclical cough, hemoptysis, chest pains, cyclical scar swelling, fatigue, and infertility. What is the strong recommendation is in women with suspected endometriosis, further diagnostic steps including imaging should be considered even if the clinical examination is normal, which our first speaker has categorically told everything about this. The another is both diagnostic laparoscopy and imaging combined with empirical treatment, that is hormonal contraceptive or progestogens, can be considered in women with suspected of endometriosis. There is no evidence of superiority of either approach, and pros and cons should be discussed with the patient. What it means is that previously 2014 guidelines was saying diagnostic laparoscopy or laparoscopy is must and it should be a gold standard for diagnosis of endometriosis. But now with the imaging criteria, you can diagnose endometriosis and there is no need of doing laparoscopy for each case. So this is the current change in the version that laparoscopy is no longer the diagnostic gold standard and is only recommended in the patients with negative imaging results and or where empirical treatment was unsuccessful or inappropriate. Now, why this question always comes, does diagnostic laparoscopy compared to empirical medical treatment result in better symptom management in the women with suspected of endometriosis? There exists a widespread concept that laparoscopy is accepted as standard to diagnose abdominal endometriosis, which was formulated in the first edition of guidelines way back in 2005. However, laparoscopic surgery, albeit its widespread use, is expensive, invasive, and associated with morbidity or mortality in some cases. On the other hand, direct photographic and histological proof of lesions could potentially be an important psychological factor for women who have been suffering from the symptoms of an otherwise invisible disease, creating a platform of acceptance for themselves and their environment. The benefits of laparoscopic surgery need to be weighed up against its risks, and practically a two-step approach should be sought, which would include a transvaginal, wherever possible, ultrasound, followed by empirical treatment if the patient is not trying to conceive. Particularly in the primary care setting, if endometriosis is suspected, imaging results are negative and the affecting person is not acutely trying to conceive, symptomatic patients usually are offered hormonal treatment, mostly in the form of OC pills or progesterone as first line of treatment. If symptoms improve, endometriosis is presumed to be main underlying condition in these cases, and the blinded approach is widely known as empirical treatment, and that is accepted. So to conclude, both diagnostic laparoscopy and imaging combined with empirical treatment can be considered in the women who is suspected of endometriosis. There is no evidence of superiority of either approach, and pros and cons should be discussed with the patient. So this is the first change which has come in the 2022 February guidelines. Now we come to the second thing, that is the treatment approach. First was diagnosis. So analgesics, women may be offered NSAIDs or another analgesic, that is weak recommendation. What GPP is, GDG recommends that clinician take a shared decision-making approach and take individual preferences, side effects, individual efficacy, cost, and availability into consideration when choosing hormone treatment for endometriosis associated pain. It is recommended to prescribe women an LNG releasing IUS system or an estrogen releasing subdermal implant to reduce endometriosis associated pain, that is strong recommended. Also, in progestagens, it is recommended to prescribe women progestagens to reduce endometriosis associated pain. That is the first line of treatment. The strong recommendation for GnRH agonist is, it is recommended to prescribe women GnRH agonist to reduce endometriosis associated pain, although evidence is limited regarding the dose or duration of the treatment of GnRH agonist. So GnRH antagonist, it can be considered to prescribe women GnRH antagonist to reduce endometriosis associated pain, although evidence is very limited and it is not to be used and it's a weak recommendation. So GDG recommends that GnRH antagonists are prescribed as second line drugs due to their side effect profile. So studies of GnRH antagonist treatment support their use and additional treatment option if COC or progesterone fails, that is a first line, and recent data indicate that post-operative medical treatment may be beneficial towards pain management and support a recommendation to offer it in women not desiring immediate pregnancy. Danazol, antiprogestogens, Luna and PSN are no longer recommended in these treatment guidelines for pain. Now coming to the surgical treatment. It can be concluded that Luna is not beneficial as an additional procedure to conventional laparoscopic surgery for endometriosis, as it offers no additional benefit over surgery alone. Presacral neurectomy is beneficial for treatment of endometriosis associated midline pain as an adjunct to the conventional laparoscopic surgery, but it should be stressed that PSN requires a high degree of skill and is associated with increased risk of adverse side effect of the surgery like intraoperative bleeding, post-operative constipation, urinary urgency, and painless first stage of labor. So it should be taken with a pinch of salt. In summarizing the surgical approach, literature is unambiguous regarding some aspects of treatment of women with colorectal endometriosis. It should be done always in a multidisciplinary setting with minimally invasive approach aiming to radically remove all endometriotic lesions. The newcomers should not start doing colorectal surgery. Those with experience and those who are working in the endometriosis units are the people who should test these patients of colorectal endometriosis. As Dr. Shweta has said, laparoscopic approach is preferred because it is associated with better post-op recovery, shorter hospital stay, and better cosmetic outcome for the patient. What about the medical therapies as an adjunct to surgery? Everybody is very keen about the post-operative women with endometriosis. Overall evidence is very poor for benefit of physiotherapy in women with pelvic pain, and adverse events are unclear. Additionally, it is very difficult to extract specific components of physiotherapy intervention, as human interaction and communication skills and patient-centered care will affect all intervention. As such, no recommendation was formulated on this non-hormonal treatment, that is physiotherapy, massage, and trigger point release therapy. Now, the most important part comes: treatment of endometriosis associated with infertility. In infertile women with endometriosis, clinicians should not prescribe ovarian suppression treatment to improve fertility. What is that? Women seeking pregnancy should not be prescribed post-operative hormone suppression with the sole purpose to enhance future pregnancy rate. These women who cannot attempt or to decide not to conceive immediately after surgery may be offered hormonal therapy, as it doesn't negatively impact their fertility and improves the immediate outcomes of surgery for pain. In infertile women with endometriosis, clinicians should not prescribe pentoxifylline or other anti-inflammatory drugs or letrozole outside the fertility doses to improve natural pregnancy rates. An operative laparoscopy could be offered as a treatment option for endometriosis associated infertility in ASRM stage 1 and 2 endometriosis, as it improves the rate of ongoing pregnancy by operative laparoscopy itself. Everybody should consider operative laparoscopy for the treatment of endometrioma associated infertility, as it may increase the chance of natural pregnancy in stage 1 and stage 2 or ASRM stage. Although no compelling evidence exists that operative laparoscopy for deep endometriosis improves the fertility, operative laparoscopy may represent a treatment option for symptomatic patient wishing to conceive. GDC recommends that decision to perform surgery should be always guided for presence or absence of pain symptoms, patient's age, patient preferences, and history of previous surgeries, and presence of other infertility factors other than endometriosis. What is her AMH, that is ovarian reserve, and estimated fertility, endometriosis fertility index of the patient. So GDG statement is that women should be counseled of their chances of becoming pregnant after surgery, to identify patients that may benefit from ART after surgery. EFI should be used as it is validated and reproducible and cost effective, and the results of other fertility investigation such as partner sperm analysis, dual testing should be done prior to that. So the extended administration of GnRH agonists prior to ART treatment to improve fertility, to improve live birth rate in infertile women with endometriosis, that is ultra-long protocol, is no longer recommended due to unclear benefits. The endometriosis fertility index was added as a step in the treatment, as it can support decision making for the most appropriate option to achieve pregnancy after surgery. These are new 2022 guidelines. The most important thing which comes after the endometriosis surgery, how much ovarian reserve you have got down. If there is a bilateral chocolate cyst or bilateral ovarian endometrioma, it has been found that the AMH falls down a lot. So that is why the fertility preservation issue has been tackled in 2022 guidelines. Thank you. Patients with severe endometriosis, particularly bilateral endometriomas, are at a high risk of premature ovarian insufficiency, which we talk as POF, and lower AMH levels. Surgical treatment can further impact AMH. The relevance of pre-treatment AMH levels to predict the chance of future pregnancy or the need of fertility preservation is unclear, as studies reporting on this have made conflicting conclusions. Fertility preservation is a valid option in endometriosis. Of importance is the high rate of women coming back to thaw their gametes. Although this doesn't equal systematically recommending oocyte banking. The high rate and short period of time between storing and thawing of their oocytes suggests that the larger population of the women did not undergo proper fertility preservation, but conversely, the oocyte freezing was a part of strategy of their infertility treatment. That means so many times it has been preserved as a treatment option that AMH is going to fall. So it is when ovarian stimulation is not possible or declined by the patient and surgery is performed for large endometriomas, the preservation of ovarian tissue can be an alternative option of fertility, although the data in the women endometriosis are less. So oocyte preservation, though is expensive and exposes women to some clinical risk, the study shows that feasibility of fertility preservation in women with ovarian endometriosis still has many questions and it remains unanswered, and there is currently insufficient data to support fertility preservation for all women with endometriosis. So it has been recommended that for some women with endometriosis, fertility preservation may increase their future chances of pregnancy, but there is no evidence or criteria to select those women. Based on this consideration, the GDG formulated a strong recommendation for counseling and information provision before going for a fertility preservation. So whenever there is a bilateral endometrioma which has been getting operated, or where the size of the endometrioma is too large or AMH levels are less, these are the patients where it is always better to do preservation. Otherwise, it is not recommendation. How should a patient with recurring endometriomas or recurring symptoms be managed? Is it repetitive surgery effective for symptoms associated with endometriosis? The medical treatment for recurrent endometriosis has been described by many of the studies, and the drugs like Dynogest and Depotleupride showed a different side effect profile, fewer hot flushes and vaginal dryness with Dynogest, less vaginal bleeding and weight gain with leupride acetate. Another RCT has shown that recurrent dysmenorrhea or pelvic pain after conservative surgery, and both treatment result in significant decrease of VAS scores at 6 months compared to the baseline. So anytime it is always, whenever fertility is the issue, you should not do a recurrent endometriosis surgery. But whenever you are doing a surgery, the job should be complete. Don't just puncture and leave, remove the complete endometrioma. Cystectomy is always better than the ablation. Sclerotherapy is there a role, but in very limited cases. So always better to do a complete cystectomy. So the last part is endometriosis and adolescent. In adolescent, clinician should take a careful history to identify possible risk factors for endometriosis, such as positive family history, obstructive genital malformation, early menarche or short menstrual cycle. There we should consider endometriosis in young women presenting with cyclical absenteeism from school or with use of OC for treatment of dysmenorrhea. In adolescent, clinicians should take a careful history and consider the following symptom as suggestive of presence of endometriosis, and transvaginal ultrasound is recommended to be used in adolescent in whom it is appropriate as effective in diagnosing ovarian endometriosis. If a transvaginal scan is not appropriate, MRI, transabdominal or transperineal or transrectal scan may be considered. Serum biomarkers are not recommended for diagnosing or rooting endometriosis in adolescents. The treatment-wise, the GDC recommends clinicians consider NSAIDs as treatment for endometriosis-associated pain, especially if the first line of hormone treatment is not an option. In adolescent with laparoscopically confirmed endometriosis, and associated pain in with whom hormonal contraceptive or progesterone therapy has failed, clinician may consider prescribing GnRH agonists for up to 1 year as they are effective and safe when to enable histological confirmation of the diagnosis of endometriosis. GDG recommends that clinician acknowledge the uncertainty toward the risk of malignancy in postmenopausal women, and if a pelvic mass is detected, the workup and treatment should be performed according to the National Oncology Guidelines for every patient with endometriosis in a postmenopausal patient. Postmenopausal women with endometriosis associated pain, clinician may consider aromatase inhibitor as treatment option, especially if surgery is not feasible. And even those patients with extensive pelvic endometriosis, whenever you are doing a hysterectomy, post-operative aromatase inhibitors are effective. Menopausal symptoms in women with history of endometriosis, they consider combined menopausal hormone therapy for treatment of more postmenopausal symptoms. So is hormone treatment effective and safe for relief of menopausal symptoms? Whether hormone replacement therapy now, which is called menopausal hormone therapy in postmenopausal women with history of endometriosis effective and safe? Efficacy is assessed by the impact of treatment on menopausal symptoms and menopause-related quality of life, while safety is assessed by the risk of recurrence of disease or associated symptom and incidence of cancer. A distinction is made between natural and surgical menopause. So last few words about extrapelvic endometriosis. Clinicians should be aware of symptoms of extrapelvic endometriosis, such as cyclical shoulder pain, cyclical spontaneous pneumothorax, cyclical cough or nodules which enlarge during menses. It is always advisable to discuss diagnosis and management and in a multidisciplinary approach. And for abdominal extrapelvic endometriosis, surgical removal is preferred treatment when possible to relieve the symptoms. Hormone treatment may also be an option when surgery is not possible or acceptable, or the patient is not fit for the surgery. For thoracic endometriosis, hormone treatment can be offered. For asymptomatic endometriosis, the GDG recommends that clinicians should inform and counsel women about any incidental finding of endometriosis. They should not routinely perform surgical excision for asymptomatic patients, and clinicians should not prescribe medical treatment in women with incidental finding of endometriosis. And lastly, the routine ultrasound monitoring of asymptomatic endometriosis can be concerned. Can we prevent endometriosis? The last two slides, primary prevention, although there is no direct evidence of benefit in preventing endometriosis in the future, women can be advised of aiming for healthy lifestyle, diet, reduced alcohol, and regular exercise. The usefulness of hormonal contraceptive for prevention of endometriosis is uncertain, so it's a weak recommendation. Lastly, the genetic testing, which is coming up very effectively in endometriosis and which is going to be the future of endometriosis. The genetic testing in women with suspected endometriosis should only be performed in research setting. That is the underlying, because if you search for recent advances in endometriosis in PubMed, you find a lot of hormonal newer genetic testing which are coming up, but they are only for research purpose. Endometriosis is a disease where daily treatment options are changing. That is why, and even more surgical treatments are coming up. That is why ISHRE has come up with guidelines and it has replaced 2014 guidelines. So the underline is they have replaced 2014 guidelines. I'm thankful to SOGS Society for giving me this opportunity to talk on a theoretical topic of endometriosis and ISHRE guideline. Thank you so much.
Hello. Thank you, sir. Thank you very much for your excellent presentation and making this topic, which is a very theoretical, and the guidelines were very complicated, making it more and more in stating simpler way. Now, you are rightly said that the laparoscopy is not a gold standard method. Now, advanced imaging science has came up. Also, you have stated that the treatment modalities, various recent modalities in infertility, pain-related, fertility preservation in large ovarian endometrioma, etc. This is a very interesting and making a very simple way to present the guidelines which was declared in March 2022.
Thank you so much, sir.
Any questions from audience?
No. See, when I was searching for the topic, there are so many newer mRNAs, newer genetic markers are coming up, but they are not to be used right now. And that is why I have not gone into the details, but there are so many papers, they are coming up, but it is only for the research purpose. As everybody knows, all the diseases are going to go to the genetics in future. Maybe it's diabetes, PIH, everything, but I am not very aware of the genetic markers, sir. Right, sir.
Even I have one more question. I was wondering that we all read when we say recent management of endometriosis, cabergoline and
Dynogest.
Yes. So is there any recommendation that you can use cabergoline in the ISHRE guidelines?
There is no recommendation about the cabergoline, but there are recommendations about the Dynogest. They have come up with the medical management of Dynogest in the post-operative period, though where the patient is not willing for the fertility. So that is for helping the patient for post-operative pain reduction, as well as the other effects of dyspareunia and dyschargia if they are not corrected. Because madam, as you are doing a lot of laparoscopic surgeries, the aim, as you know, should be complete removal of every endometriotic nodule.
Hello.
So many times it is
मी
only
conference मध्ये नंतर करतो. Okay.
So what ISHRE has specifically guidelines is that whenever you are doing a surgery, you do a complete job with the endometriosis in it itself. But those patients who are having certain pain because of the peritoneal factors, where medical therapies like letrozole or Dynogest or even a leupride depot is going to be effective for this patient. The time period they are not mentioned, but it is not more than 1 year.
Hello.
Thank you.
Thank you so much.
I request our chairpersons and Anjali Jamma madam to please felicitate Dr. Kalyan Baramde sir.
Hello. Check. Hello.
Hello, Dr. Sandesh Kade is going to talk on adenomyosis and its management. Dr. Sandesh Kade from Solapur, we know that he is recognized as an authority in laparoscopic surgery. At present, he is a managing director at Sunrise Hospital, Solapur. He has worked as an endoscopic surgeon at Solapur, Mumbai, Delhi, Dubai, and now at Bahrain International Hospital. So he is working at so many places. His specialty in endoscopic surgery includes fertility enhancing surgeries, recanalization of tubes, laparoscopy for pelvic floor repair, difficult hysteroscopies, hysterectomies, moderate to severe endometriosis, fibroids, etc. He has trained over 200 gynecologists across India up till now. He has won the best video, he has won the prize for best video for uterine artery occlusion in difficult hysterectomy and myomectomy at ISG international conferences. So we welcome Dr. Sandesh, and he is going to talk on adenomyosis and its management. Welcome you, sir.
Thank you.
Start.
Thank you. Thank you. Yeah, thank you very much for those words. At the outset, let me thank Solapur Obstetric Gynec Society for this wonderful opportunity. Actually, I had told Madam Jamma Madam that I am here without my laptop. So I have actually requested the hotel to give it to me for some time. And I would better participate in the panel discussion. But she said, no, we want to hear what you feel about adenomyosis. So there are no slides, but I will just share about adenomyosis and what I encounter in my private practice. So as a student, if you remember, the concept of adenomyosis was that only parous women and elderly women who undergo hysterectomy, the histology would tell the doctor that, okay, this big, large uterus has adenomyosis. So adenomyosis was getting diagnosed in elderly women who already had children. And now when we see in our clinical practice, we see a lot of young girls coming up with adenomyosis. Secondly, when we go into the infertility conferences, they always try to correlate, although it is not the exact correlation that has been found, but they say that we face infertility in lot of adenomyosis patients. So while I was learning, they said it is in patients who have lot of children and are elderly, and now we say it is in patients with infertility. So this is a very contradictory statement that associated with both parity and infertility. So we have to understand that adenomyosis may be different phenotypes and not only one which is associated with for infertility or the other like that. We have to understand that way. Secondly, the another factor which I find in my clinical practice is that when you go for performing the surgery, sometimes it's a very, very difficult surgery, whereas sometimes the uterus is very clean. So we have to understand that adenomyosis can start from inside out, that is the junctional zone gets breached or the endometrium gains access into the myometrium, and then it forms an clots bleeding spaces, the glands go inside the myometrium, they bleed, and there is hypertrophy of the surrounding myometrium. So this is inside out. Whereas in surgeries, when I go, I find that there are a lot of bowel adhesions. The posterior pouch of Douglas is obliterated. Are the types which are outside in. So these are totally different factors. And the association very often that adenomyosis along with endometriosis is very high. It has been shown up to 22 to 26% that a patient of endometriosis will have adenomyosis. And when patients have severe excruciating pain, the association is found to be more again. And if at all you have myomectomy to be performed, there are all these three conditions. We have a lot of patients like this where we have gone for a submucosal thyroid repeated implant failure, and you find severe adenomyosis and endometriosis. So we really have to understand, and why is these things happening? Why are we not coming to a good conclusion and guidelines in adenomyosis? Although this disease was described 100 years ago, is because a lack of good classification system. So the first classification came as in 2004, and that was again still in the evolving phase, because it was MRI based only, where they showed whether the junctional zone is thickened, whether it is more than 8 millimeters or up to 12 millimeters or more than 12 millimeters. But actually after 2004 till 2014, again for 10 years, nothing was there. It was in 2014, the first surgical and histological based classification came, where they divided it into focal adenomyosis, diffuse adenomyosis, sclerotic adenomyosis, or cystic adenomyosis. These all types were described. And it started becoming easy for us to pick up which cases we should operate, which cases we should go for medical line of treatment. So classification, all speaking, the whole speaking on same language is very important for us to have good guidelines and understanding. So now what we follow in our practice is there are different treatment modalities available. One is you can go with conservative medical line of treatment. You can go with conservative treatment such as HIFU, or you can go with intra artery embolization. In surgeries, again, you can be conservative. Why we are speaking more and more of conservatives? Because more young and young girls are coming up with adenomyosis. So you have conservative line of surgeries for adenomyosis and the radical, that is the hysterectomy. So who are the patients we have to discuss is who are the patients going to go for conservative line of treatment in adenomyosis, and are we justified in performing? So before taking the patient for adenomyosis surgery, very good ultrasound diagnosis has to be made. The sensitivity and specificity of ultrasound has gone almost 99% now. Specificity and sensitivity is up to 90%. So there are 7 clinical signs, the ultrasonographical signs, which tell us about the adenomyosis. I remember we used to label it as fibroid, and in conferences, that poor faculty who used to come saying, I am operating a fibroid, and used to find a adenomyoma. And it used to be a very pathetic situation for him. So now you have MUSA guidelines, which classify between a fibroid and a adenomyoma. So understanding the ultrasonographic features to differentiate it into a fibroid and adenomyoma is the first thing that has to be done. It is like when I talk to my patients, I give them an example of like sand. So if you have an egg in the sand, you can pick up that egg and still the sand remains intact, and that is fibroid. But if you have sand and you put some glue, and that certain area gets glued and forms a mass, and when you remove the same mass equal to that egg, using a lot of sand. So what I mean to say by this is that if there are 100 cells in the uterus, one cell will form one fibroid, even though it is 2 centimeters or 5 centimeters or 7 centimeters. When you remove that 5 centimeters, only one cell is lost. So fibroids are monoclonal. Whereas if you remove a 2 centimeter adenomyoma, you might lose 10 cells. If you remove a 5 centimeter, you might lose 30 cells. Or if you remove 7 centimeters, you might even lose 60 to 70 cells from the same uterus. Why is this important? Because the rupture rates are very different. If you remove a fibroid and adenomyoma, the rupture rates in antenatal or the intrapartum is very, very high in adenomyosis. And that is the reason we have to be careful in selecting which patients are to be operated and which are not to be operated. So always after a good diagnosis, understand the benefits versus the pros and cons before we put a knife on her. Next is depending on the size and site, whether it's anterior, posterior, fundal. So all these factors matter. If it's a diffuse adenomyosis, better go on GnRH treatment. Or if at all you need to operate, then better do a laparotomy in cases of huge diffuse adenomyosis. But when it is focal adenomyosis, then I always prefer to perform the laparoscopic approach. Now, when you are doing conservative surgeries, who are the patients who will ask for conservative? They are young patients who are still to have babies. So they will say, I want to preserve my uterus. There are young girls with severe dysmenorrhea, menorrhagia, who are not able to continue their life. So these patients need these conservative surgeries. Then there are patients who come to us from the fertility centers with repeated implantation failures, distorted uterine cavities. So these patients, we need to do a conservative surgery. Now in conservative surgery, again, I give them an example of the brain surgeon. If you have a brain tumor, there is no point removing complete brain tumor and then the patient cannot remember or cannot talk or cannot walk. So there is no point removing the whole brain tumor. You have to be partial in that. You have to be more functional than radical. So does that concept work in adenomyosis? Yes, in most of the symptoms of adenomyosis, partial adenomyomectomy works well. So what are those conditions? So you have clinically three types of patients. One with severe pain, second is with the infertility. So when you want to do, and third is the bleeding problem. So these are the reasons why the patient will opt for surgeries. So if you are dealing a patient with pain and bleeding, partial adenomyomectomy can still suffice, like the brain surgery. But if you are dealing with a patient of infertility, then it is better to do a complete resection. But the question is, if you do complete resection, what about the rupture in the antenatal and the intrapartum period? So we have to understand the closure methods, how we are closing. Initially, when we were going with as a fibroid and you used to remove wedge resection, it used to be very difficult to bring this uterus close. Then came the techniques that, okay, let us undercore the adenomyoma and overlap the tissues. Finally, we are now performing in focal adenomyosis something called as the triple flap technique, and we have a lot of patients with triple flap who have conceived. So now I'll just try to share this video with you of a can you just allow me to screen share some the host?
Hello.
Yes.
Allow केलेला आहे sir.
Okay, I'll just start that. 1 minute. I'll start that video and then share it.
Sir, we have your video. Can we start from here?
You have I don't think my daughter has given a very different video to you.
Okay. Okay.
Just give me a moment. Yeah. Okay, so now do you have this video? You have this video there?
Yes, sir.
Okay, so this is a case of anterior adenomyoma. And here we are performing triple flap technique. So what we do is a T-shaped or an inverted T-shaped incision depending upon its position and location. See, anterior adenomyomas are easy to perform, while the posterior ones are very difficult if they are adherent to the rectum. So here we create a T-shaped incision and you get 2 triangular flaps and 1 horizontal flap, and the adenomyoma is removed. Now the steps are standardized for closure. What I want to highlight here is more the closure technique, in which we start with the lowermost flap, and we always start from right side to left side. Care is taken to see that there is no free area in between, and it is completely approximated, because hematoma formation is one of the very important factors which decides the rupture rates. So this is the step 1, which goes from right to left end. Now we come to step 2, where we overlap, we go from inside out. This is 2A, because these steps are very standardized, where we actually now approximate or overlap the lateral flaps. So in the 2A part, we always fix the lower end of the lateral flap on the serosa. So here the adenomyoma has been removed with actually keeping flaps of almost 0.5 centimeters on all sides. So 2B and 2C are the areas of closure of the vertical closures till you go to the apex of the lateral flap. And then in step 3, we go from inside out to the remaining flap, which again overlaps on the flap 2 and flap 1 partially. So here you get very, very good closure of the flaps, very good thickness. We have followed up these patients with 1 month scan, 3 month scan, and 6 month scan. So whenever you perform adenomyomectomy, follow them up with ultrasound and Dopplers. When you get good healing, no hematoma, and post healing after almost 6 months, allow them for pregnancy. What you use in this surgery, whether you use electrosurgery or cold scissors, matters a lot, and it has been shown that you should use scissors for the excision purpose. And how you suture the flaps, how you heal it, and when do you allow the patient to get pregnant, all these factors play a very, very important role in preventing future ruptures in the patients. What has been found world over is that lot of studies were started, and due to rupture rates, these studies were given up. So practically now world over, nobody is working on these surgeries for these patients, and these helpless patients are moving from door to door asking for help. So we really need to first start classifying our patients, selecting them properly into the surgical methods, documenting their results. And when we have a very good follow-up with their post-delivery data, maybe we might again come back to performing a good surgical technique for these patients. Now, this triple flap technique works very well for us in focal adenomyosis when it is inside or when the serosa, but in cases of outside in disease, which is called as foam, there we are finding it slightly difficult, because overlapping with 3 flaps is slightly a big challenge right now. But soon with MRI, we are understanding that how much is the thickness to be removed, and then we go undercoring the myometrium and then creating the flaps. And definitely, I think we will soon have a lot of work will happen, and we will be there to help these women. Thank you very much for this wonderful opportunity. If you have any questions, I would be glad to answer them.
Hello. Thank you, Dr. Sandesh. You have very nicely elaborated this, and we are very clear with this conservative surgeries for partial adenomyomectomy, where the triple flap technique will work very nicely. And I think more and more work will be done in next few years on this. Thank you very much.
I request our chairpersons and Jamma ma'am to felicitate the Sandesh Kade sir by providing the e-trophy.
I can see it. I can. Thank you so much.
Any questions from audience? Questions from audience?
I request Dr. Jamma ma'am, please felicitate our chairpersons. As we are running short of time, I request everyone, please have a lunch inside the hall. As UK speakers are joining sharp at 2:10 p.m. We will have a panel discussion in between the talks. Deshpande ma'am, please moderate the panel. I invite our panelist. Ma'am, Mike.
Dr. Shashikant? I think he has just gone out. Please have a sit down. Dr. Shashikant, please join us. Dr. Milin, please come in with your plate. Dr. Kalyan is here. Okay. He's left. Dr. Archana, is Dr. Kalyan around? Did you ring him? Huh? Is he coming? Huh? Okay, Dr. Kade is around? Kunala. I think we can have Dr. Yes. Can we request Dr. Dabde to come on the dais, please? Dr. Dabde, please come on the dais. I think Dr. Milin will join us in a minute. He's having his lunch. Good afternoon, everyone. After the sumptuous lunch, we are all back and we are still interested in knowing more and more about endometriosis. Thank you very much, President Dr. Anjali Jamma and Dr. Archana, Dr. Monica for giving us opportunity to be here for the panel discussion. As we know, the endometriosis is a it is a big spectrum by itself and there are a lot of challenges involved in it. So let's discuss some of the cases. I also welcome Dr. Sandesh, who is going to be online with us. Dr. Milin, you can come on the dais. Yes. So, you know, I'm very thankful to all the panelists who are here. Dr. Bharat, he is from Hubli. He is a teleradiologist. And we have listened to his talk just in the morning and everybody has appreciated his talk and impressed by his skills in imaging. Dr. Sandesh, of course, he's going to be online with us. Dr. Shweta, she is a very enthusiastic endoscopist from Dr. VM. So she's with us. Very nice to have her. Dr. Kalyan is not there. Dr. Dabde is filling in the gap, but then he is always with us for any of the academic meeting. And of course, Dr. Shashikant, IVF specialist. We are very happy to have you, Shashikant. And Dr. Milin will join us soon. Now let's start with our first case. This is for you, Dr. Dabde. This is a young student, 18-year-old. She's unmarried, of course, and she has presented with severe dysmenorrhea on day 5 of the cycle. She has had menarche at the age of 11 years and has painful menstrual cycles for last 2 years. But the flow is quite normal and moderate. She's been taking analgesics, but it is not working for her at the moment. She has to leave from college and take rest at home.
Yeah, any young patient coming with this chronic abdominal pain with severe dysmenorrhea, we should all keep in mind endometriosis as the very important cause of this. And the delay in making this diagnosis and treatment worsens their prognosis, both from a fertility point of view and quality of life both. So first statement I would like to make here is gynecologists should have high index of suspicion when an adolescent presents with this pain. And when I started my practice and few years after that, laparoscopy was considered the gold standard in diagnosis. And it was said that we should not delay doing laparoscopy even for these young girls, so that you can achieve early diagnosis, pick up these cases and put them on the medical line of treatment. But now, as just we have, all the speakers have repeatedly told that laparoscopy is no more the first line of investigation in these patients. But some whatever the imaging modalities now beautifully we have, we should be going ahead with the diagnosis.
A very valid point. That any girl who is coming with dysmenorrhea, of course, we think of spasmodic, but when it gets like congestive type of dysmenorrhea lasting for more period of time, or it comes premenstrually, then not responding to any medications, then what would be the first line of treatment that you would think? Of course, you will do the imaging, right? So how images is going to help? In this patient, she had a transabdominal sonography, which has reported as a uterus being normal in size, right ovary is normal. The left ovary is showing a cyst of 2.3 by 3.2 centimeters with some echoes in it. Could be a hemorrhagic cyst or could be a endometriosis. So are there any risk factors you think in this patient which has made her predisposed for endometriosis?
Not really, because the cyst of 2 by 3.2 centimeters, I would quote it depending on the menstrual phase in which she was probably scanned. Okay, many times even the corpus luteum would also present in the same way.
So differential diagnosis you have to really make whether it is a corpus luteal cyst or whether it is an endometriosis. So straightforward. So Dr. Bharat, do you want to give some inputs, like would you straight away make a diagnosis of endometrioma, or you would like to?
On transabdominal
sonography,
it is very difficult to differentiate the two. So I would again.
Hello.
I would again give the same differentials. Then corpus luteum, if I have to rule it out, I'll put color Doppler and see whether the peripheral flow is there or not there. So that will rule out one of the diagnoses. And even still in doubt, as I spoke today morning, if the patient really agrees, because we cannot do a transvaginal sonography, patient is very young. So transrectal, I would give one advice, we can go ahead with transrectal, which she might not actually agree for, and then call her after 8 weeks and see whether the cyst is regressed or still there.
Yeah, I think a very good point that he has told us, that you might as well put a color Doppler and see whether if it is having a good flow, then probably it is a corpus luteal cyst.
But because we are doing the transabdominal scan, the area of interest is quite away from the probe. And even with the good machines, we may not be able to catch the color for this distal tissue. So I beg to differ. I mean, it may not always work in all the patients. So
So now we have tools, something called as power Doppler.
Power Doppler, yes.
So the moment you put power Doppler, even the minute of the minute blood supply, it picks it up.
One more comment on that, especially it's a rather question to you, Bharat, that we know that MRI has that ability to detect between the blood and the clear fluid. So whether MRI in this particular case, where repeated attempts were done to diagnose her actually the disease, whether MRI will put some light on that, because we do that sometimes in some of these cases where we find, yes, it is helpful. And then we supplement it with sometimes with the markers also, the CA125 to get an idea. But what do you say on that? MRI is having an additional benefit?
Sir, MRI do have, but then if you see this patient, I don't find any harm in she waiting for 8 more weeks, because if my MRI again gives the same DDs, sir, because not every time I will see that T2 shading. Because if it is hyper intense on all the T1FS and T2 images, I might call it as it is probably hemorrhagic, but then she can wait for another 2 months and then come back.
Yeah, so now we have come to the conclusion that imaging can be done and preferably a transabdominal sonography, and this will throw a light whether it is a endometrioma or whether it is a corpus luteum cyst, which is a likely diagnosis. And of course, it can be repeated after 6 to 8 weeks to see whether this cyst is persistent or it will go away. What kind of, if she's having pain, how do you treat, Dr. Milind?
Basically analgesics, they are very important, and here we need to use the various analgesics. I mean, quite often we give dicyclomine, and quite often the patient there is constipational spasmodic dysmenorrhea, but sometimes rotavirin also makes a wonderful change. So we have seen the patients who come to our clinic where they have been receiving actually the typical combination of mefenamic acid and the antispasmodics, and when we give them the rotavirin, they are very relieved sort of thing. That is the thing. Sometimes in very agonizing pain, injectable is also another option to relieve that particular pain cycle.
But how will you halt the progression of the disease?
Then we'll have to think, once we clinch the diagnosis, then we'll have to think about the various other options to, suppose it is turned to be endometriosis by my actually evaluation. Naturally, we start with the medical management of endometriosis.
So what kind of a medication would you like to start on?
Yes, normally in these particular patients, we always start with 4C pills because these are very safer in these young girls. We directly don't jump for the aromatase inhibitors, or we never jump for the GnRH analogs. Quite often they work very well. Nowadays, we started doing, especially in my hospital, giving the combination of 4th generation progesterone, that is Danogest plus ethinyl estradiol. And that also gives a wonderful result in this particular young
4th
girls.
generation?
Progesterone, Danogest. That is a combination available, Danogest plus ethinyl estradiol.
Yes.
Instead of giving the regular ethinyl, the Norgestrel, we give this combination.
Any
and
role
that
of
gives a good result.
any role of danazol, Dr. Shashikant?
Danazol for her, madam, it will not work because fertility is her issue after the marriage, because she is so young. So danazol we will not prefer in her case. And as such now, it has been shown by Dr. Kalyan that in the management of endometriosis now it has been banned by ICH.
And danazol is almost out of prescription now because more of a suffering rather than the benefit of danazol.
Rather, with danazol, the spiroff acid very nicely.
Yes.
You convert very nicely,
young girl
cute
into-
girl to a virilized male. So
it
especially
should
young
be
girls
always
are
avoided.
so concerned about their looks.
Yes.
So the danazol won't be the option.
Dr. Shweta, suppose this girl doesn't respond at all, and maybe after 6 months we find that she's not responding, she's still having a debilitating pain, and maybe the endometrioma size also has progressed. So when is the time that you think that endoscopist will come into picture?
I would still think it's not a time for endoscopy. She's a young girl, and we always believe that you should do only one surgery for endometriosis, and most of the time that should be for a fertility enhancing reason. So since she's an adolescent girl, surgery should be delayed or avoided as much as possible. So now we can go to the second line of treatment. We can put her on GnRH and see how the effect of GnRH works. And post GnRH, she can go back on the COCPs so that we maintain the size of the endometrioma.
I think we got a good message that we have to actually delay the surgery as far as possible, unless they come with some acute pain or something like that, with the rupture of chocolate cyst, which can happen occasionally. But for all the practical purposes, we have to delay the surgical procedures and we have to do the medical management. And most important valid point over here is we have to have a high index of suspicion. As Dr. Raju emphasized that if we diagnose this condition in time, we should be able to actually halt its progress. Yes, you want to say
Yes,
something?
no.
The but is a big but in this case, as you said, this medical treatment. The question is how long we should be continuing this medical treatment for a adolescent girl, because the day you stop this medical treatment, even in few months, if she was a real case of endometriosis, her symptoms are going to recur again.
The another thing that the dilemma is, if the patient is around 24, 25 and does not plan on getting married or conceiving, but has severe endometriosis, we can ask her to get egg freezing done first. And then we can actually go oocyte preservation, and then we can go and do a surgery for endometriosis with a good technique where we don't destroy too much of the ovarian structure. And later we can keep monitoring her AMH levels, but in case they drop significantly, she still can bank on the eggs she has frozen when she's actually willing for pregnancy.
Yeah, that's true. But she was never concerned about her fertility in her adolescent life. Her main concern was about her chronic abdominal pain and more so severe during the menstrual cycle or post-menstrual cycle. In that case, what I discussed with Sandesh a long back is nerve ablation. Okay. They have been doing now endoscopy. They injected dye so that the nerves will be popping out. So they could really see where the nerves are and they could selectively ablate those nerves. That's what I learned.
I think we have to be minimally invasive. That is what I thought.
It depends. I mean, it depends upon how severe or how much her life is being disabled because of this pain.
Yeah, that's what we say. Symptom-based approach is always important. It doesn't matter the patient, the fertility is always secondary to the patient's QOL. So if the patient is really suffering, you should do a surgery. But as far as possible, try to avoid surgery for endometriosis, because first surgery has to be the best. And first surgery has to be the last surgery.
True.
And whenever we decide of choosing diagnosis, we'll have to give at least for 6 months, maybe in the combination, maybe as a sole agent. But 6 months is very
6 months
important to
minimum
give.
is required.
Otherwise, there is always a chance of getting the inadequate treatment.
I think we are
Can
getting some.
can I add here?
Yes. Dr. Kade, you can go on.
Yeah.
Yes.
See, we have to understand that Eshrey has said laparoscopy is not the first line or not the gold standard. That is because now our diagnostic technology has improved. Initially, we were not able to exactly understand whether we should start treatment for this girl. And the another question was whether this cyst is malignant also. Now, because of very good diagnostic modalities, we are even able to tell whether this is endometrioma and whether we are supposed to look for tumor markers. So the technology improved so much. That's why laparoscopy is no more needed to diagnose. That is the meaning of this sentence. It is not laparoscopy is out of this armamentarium of the endometriosis. So in this case, we should go with, I think that was rightly pointed out, give her medication. If does not work, repeat ultrasound. If it does not work, pain keeps on increasing. Now then would be the time for MRI. And if at all, endometrioma, see the biggest problem in all the countries was diagnostic delay, and most of us picked up endometriosis when we saw endometrioma, ovarian cyst. The disease has already started before that. Many of us
absolutely.
Ovarian endometrioma is a tip of an iceberg. It is the deep endometriosis to which it goes and sticks, the peritoneal endometriosis to which the ovary sticks, and then the endometrioma forms. So
welcome. Yes. Welcome, Dr. Suruchi. Welcome to Sholapur Obstetric and Gynecological Society. Very nice to see you. We would like to have inputs from you as well.
Sure, thank you.
Thank you.
Thank you so much to all of you for inviting. I met Dr. Shah in Varanasi a few months ago. So very good to see you. And really thankful to all of you for giving me the opportunity. So my take on this is sometimes, endometriosis is such a complex disease that there are as many treatments as there are people. And, what we forget in all of this is the patient sometimes. Because, there's you will find one group of consultants who would say that, look, medical management, there's one group of consultants who are good at surgery, they want to operate on all the patients. So what my message here would be like, sometimes reaching a diagnosis is also important, because if we don't have any evidence that this patient has endometriosis, then sometimes these patients are led to believe that it is in their head. And that does, because in my setup where I operate, we have got a general practitioner and then they come to the specialist. So not all patients come to the specialist. So sometimes there is a huge diagnostic delay as in any other country. And these patients are led to believe that, women are supposed to have painful periods and you just have to get on with it. And the fact that they don't have a diagnosis and their family they think that it's a chronic sort of a pain problem, maybe it's a psychological issue. This leads to a lot of mental health issues. So while we are saying that, yes, laparoscopy is not the only thing we can do, but sometimes, when we do a laparoscopy for these patients and we find peritoneal endometriosis, we excise it. But what the patient really appreciates is, I have been suffering for so many years and I didn't know what problem was there, but now I know that there is a problem and now it can be managed. So, and I mean, the ESHRE guidelines, they are very good. But I think at the end of the day, we should not be following just guidelines. We should be treating what is best for the patient. So even if it's an 18-year-old patient who comes to us and says they have these issues, but you have to ask them what do they want? Do they want, yes, surgery has a risk of decreasing ovarian reserve, but at the same time, that endometrioma that is sitting there, it releases free radicals, it has a very negative impact on the ovarian reserve and the quality of oocytes as well. So, there is no sort of the ESHRE guidelines have not given us yes or no answers in anything. So I think the care has to be individualized. And the crux of it is doing the right kind of surgery. If you can do surgery where you can preserve the ovarian tissue rather than ablating it or completely removing the ovary, then that's all right, actually, in my eyes. I don't know what the panel think about it.
Yes, thank you, Dr. Suruchi. Is it okay if we go for a second case, Dr. Archana?
Yeah, by the time she goes for the second case, Suruchi, I just wanted to ask you, you said about this reference pattern in NHS in UK. The general practitioner has to refer the case to consultant. But nowadays, many of our patients, they contact us on various platforms like apps. So is that practice is there in the UK as well? Like patients can contact the consultants for online consultation, or it is not allowed?
No, it is. So, again, it depends on the, in UK, there is a very small population who is affluent enough to afford private care. So, and of course, if they can afford private care, they can contact the specialist themselves. But for most of the patients who cannot afford it, they have to first go through the GP, then come to the specialist.
Thank you. Let's move to the next question now for Dr. Shweta. A recently married 25-year-old lady, she has presented to urologist with a history of right loin pain, which is radiating down to the right iliac fossa on the day 1 of menstruation. And of course, her cycles have been quite regular for last 6 months, and she was taking analgesics for the pain that she was having. But slowly this pain got worse. And on examination, she is actually a febrile, no dysuria. Her CBC, urine, etc. is normal. Her urine USG KUB was done. That also showed normal, both kidneys, no calculi, no hydronephrosis, and the bladder also is normal. Now she had a pelvic scan done and it showed normal size uterus, normal left ovary, and the right ovary actually showed limited mobility and suggestion of sort of a corpus luteal cyst in the ovary with the suggestion of hemorrhage in it. The size of the ovary was 2.5 by 3 centimeter with the normal ovarian follicles around it. Left ovary was normal in appearance and she was referred to gynecologist then. So what do you think, Shweta, of this patient?
This patient could be having an early endometriosis. She could also be having some pelvic PID component also based on her history. But since the pain is typically during periods or on the first day of period, less of a diagnosis of PID, more towards early endometriosis. When the sonography suggests less mobility, that means the point of invagination, it has invaginated, the endometriosis starting off at that point. Many times we see that the early endometriosis is much, much more painful than a proper endometriotic cyst. That because the nerve endings, they are getting affected at the time of superficial endometriosis or point of invagination. So in fact, this is like a typical picture of a early endometrioma.
Absolutely. I think you made a very good point that, when it starts early, at that time, the pain is maximum. So she was given analgesic, she recovered and she went home. And she was later advised to come for a follow-up after 6 weeks, and which showed a persistent cyst. And she actually had another attack of this pain next cycle, and it was increased in its intensity and yet needed admission. This cyst had persisted and showed an even thicker wall and uniform echoes in it, and the size remained the same, persistent. So this is what, like, she had undergone a laparoscopy, and you can see here that the right ovary is actually quite like the tube is stretched over it and it has become quite edematous, and this right ovary is stuck to the ureteric region. So there are periureteric adhesions as well, and when this ovary was released from this adhesion, there was a release of that focus of invagination, and there was a dark dotted color fluid which actually came out from here. So this was like, then it was separated, and this patient actually got relief, and in fact conceived also, because and she had 2 babies later on. But point that I wanted to make was her presentation was like a ureteric colic. And these patients might land up with urologists, So,
But one more thing, Rohini, in this particular case, does this, possibility of ovarian torsion came to your mind because that ovary is having cyst?
Yes.
And the torsion is another possibility which always gives the similar
but
clinical
this cyst
picture.
was having restricted mobility, like it was not mobile, it was tender. So that was one point that you have to keep into consideration. And when the Doppler was put, there was a periovarian flow was there. So it rules out a torsion.
The superficial endometriosis is always extremely painful.
Yes,
we have seen
absolutely.
a couple of cases, in fact, one in particular, where this girl, there was no sonographic evidence, no MRI evidence of endometriosis. So first medical treatment was given, then she had done a lot of, she had gone to a colorectal surgeon in Dubai, then she had taken pain management, the dry needling and Botox injections, because nobody could actually come to a conclusion about what it is, because there is no endometriosis on any of the imaging modalities. So we decided to just put in a telescope. It was microscopic, but studded endometriosis. It was very little, those brown lesions or white vesicles over the peritoneum, over the uterosacrals. And then they were just cauterized and fulgurated at that point.
But Shweta, I want to ask you, in such cases, do you think that CA125 is of some use? Because see what we do, and then we find the levels between 60 to 90. And then we always keep in mind that there must be some endometriotic actually the involvement.
Even if the ASHRAE guideline says that it's not a marker anymore, we still use it as a marker. Because if it is a decision between hemorrhagic and endometriotic, and the imaging can't give you a clear-cut guideline, but the CA125 is slightly raised, then it actually confirms a suspicion that, yes, it is an endometriotic cyst, and we can at least start the treatment on those lines instead of waiting for 2 months for the hemorrhagic cyst to dissolve.
So a message here is any bowel symptoms or maybe urinary symptoms which are not actually correlating with the findings which are there, then you have to really think of endometriosis. Anyway, the time is up.
Has raised the hand. Suruchi
yes,
wants
Suruchi, you want to say something?
Yes. What I want to say that in this, I see lots of these cases on a regular basis, because in our setup, what we do is every patient has by the consultants themselves. So we have a one-stop clinic, you do a scan, and I think that is something that may need to change in India, because we have an over-reliance on radiologists, and radiologists are not medical, so they don't understand the disease. So for them to comment on the sliding sign, ovarian adhesions, it's very difficult for them, whereas we understand the disease. So if we start doing the scan, the quality of diagnosis for endometriosis improves. So the picture that you presented here is a very classical picture. This ovary is stuck and it is getting adherent and it is developing into a endometriotic cyst. So for such a patient who is in pain, I think the best treatment is surgical. You do a laparoscopy, you mobilize this ovary, you gently take away just the endometriotic cyst. You also at the same time do a ureterolysis make sure that, whatever peritoneal endometriosis is there in the region of the pelvic side wall, you excise that endometriosis, and that will lead to complete resolution. So what I'm trying to say is that endometriosis is almost two different diseases, which is one is peritoneal disease, one is deep disease. And while deep disease is usually easily picked up on scan, peritoneal disease is not picked up on scan. So it is okay to do a laparoscopy in somebody who's complaining of these classical symptoms. Do a laparoscopy. If you see peritoneal endometriosis, take it away, because that does lead to resolution of symptoms. And not when how much do symptoms resolve in severe endometriosis? If you remove, patient will say my pain has gone away quite a lot. In peritoneal disease, 80% of the patients will say their pain is better. 20% will say their pain may not be better because we think that is due to nerve sensitization. But it is okay to offer them a laparoscopy, because from what I'm hearing, it seems that there is a little bit of reluctance to do laparoscopy. But I think even these peritoneal endometriosis patients deserve to have a diagnosis, to have their disease taken out, and to know, I mean, the case that you're saying that the patient had to go to so many places. So that shows a tiny bit of reluctance to perform a laparoscopy. Is my understanding correct?
Yes, yes. This in this patient, it was quite gratifying, because one thing is her pain was relieved, and second thing is, her fertility also improved. Dr. Sandesh, you want to do any inputs?
I think unmute yourself.
Please unmute.
Yeah. My inputs would be that this patient was lucky that in spite of having urinary problems, she was symptomatic, because we know that urinary symptoms are very, very late to appear, and most of them it is called as a silent killer. So it is good, we should listen to what the patient is saying. If she is in pain, not getting relieved, then it is time to scope and then treat her and help her. Yeah. Peritoneal endometriosis, there are 3 endometriosis: ovarian, peritoneal, deep. Peritoneal will not be picked up on ultrasound very easily. So clinical history and listening to the patient is utmost important.
Absolutely. Thank you very much, Dr. Sandesh, Dr. Shweta, Dr. Bharat, Dr. Rajiv, and Dr. Shashikant and Milind for being with us for the panel discussion, and as well as Dr. Suruchi. Thank you very much. Now I think we are very eager to listen to Dr. Suruchi. Thank you everyone for patiently listening.
Thank you very much. Thank you, madam. Thank you to you as well for conducting given short time. Thank you very much. Okay, thank you. Thank you.
Thank you, Rohini madam. Now we are moving to this third session. I request Anjali ma'am, please felicitate Rohini ma'am. I request Dr. Anjali Jama ma'am, please felicitate Dr. Shashikant Umbardhan sir. I request Jama ma'am, please felicitate Dr. Dabde sir. I request Dr. Jyoti Raghoji ma'am and Dr. Sujata Kulkarni madam to chair this session. Dr. Jyoti Raghoji madam, she is a consultant gynecologist. She is practicing since 24 years. Dr. Sujata Kulkarni madam, consultant at Banshankari Hospital, Solapur. Welcome ma'am, over to you.
Thank you, Supriya, for those kind words. A very good afternoon, one and all. After this brainstorming session by Dr. Rohini Deshpande, Madam and team, we are just continuing the ongoing journey of endometriosis. We all know that endometriosis is a complex and a multifactorial disease. The more we think that we are confident of treating endometriosis, something new pops up. And to give us more insight on endometriosis, we have today with us Dr. Suruchi Pandey. She is a consultant gynecologist, laparoscopic surgeon, and honorary senior lecturer at George University of London, Royal College of Obstetrics and Gynecologists, London. Madam is going to talk on endometriosis, known and unknown, and how to provide an holistic care. Over to you, Madam.
Thank you. Can you see me? Perfect. Thank you. Thank you so much for giving me the opportunity. So I will give you a bit of my background. I did my undergraduation in India from Banaras Hindu University. And then I came to the UK in 2004. And since then, I have been in the UK. My postgraduate education was in Oxford, and presently I'm a consultant in London. So the thing that I'm passionate about is providing women the right care, and especially for endometriosis and menstrual problems. And because I have worked in a setting in India and in the UK, I understand the differences in the two systems. And what I want to talk about today is I don't want it to be a monologue. I want it to be more of a discussion on what is relevant to you, because, I want to see how we can, and point out things which are good in the system here and what are good in the system in India. And if we can join the two systems, then, we can achieve quite a lot. So with endometriosis care, the primary theme that comes all over the world is that women don't feel that they're listened to. And the care very much depends on who you go to. It is not multidisciplinary, it's not holistic, and rarely, women get the right kind of care. And there is an overemphasis on medical treatment. And, in India, probably women, they do not complain so much, but here, women are very aware of all the problems progesterone causes. So, there's over-reliance on progestrogens, and progestrogens are very bad for mental health in some cases. Progesterone is known to cause low mood in women. And, so women who are on progestrogens, they have got headaches, breast tenderness, PMS-like symptoms, bloating, and, a lot of other issues. So how can we sort of taper the care towards what a female needs, rather than, following any guidelines, or, how can we provide individualized care and listen to the woman is what we should focus on. So before I start, I very much want to know who the audience is and what do they want to gain out of this webinar from me. From my point of view, what I was thinking of discussing is the knowns, like what we know about endometriosis and what we don't know about endometriosis, which is we have been talking about it for ages, but we don't understand the pathophysiology of the disease. What causes pain in endometriosis? What is the genetics of endometriosis? And, while I totally understand that the first surgery should be the best surgery and should be the only surgery, but unfortunately that is not the case. Research has shown that it is a chronic problem. It's a chronic inflammatory problem, and the recurrence rate of the disease is around, up to 50% in 5 years. So even in the best hands, the best surgeons, they can't claim that, my patients don't come back. The crux of the matter is the patients do come back. And which means that we should be doing something else, looking at the pathophysiology and offering them some different treatment, looking at the physiology of what causes pain in endometriosis, and then tackling the problem, rather than just focusing ourselves either on progestrogens or GnRH agonists, which cause severe issues to a woman's mental and physical health, or just doing surgery, which sometimes, if done in the wrong hands, can cause a lot of problems as well. So how do we bring about the care for a woman, and how do we include the care for infertility, the fertility needs? How do we involve holistic care in the sense looking after a mental health of a woman? A woman should not be suffering silently in today's world, and how do we provide? That's what I wanted to talk about. But before I do that, I just want to understand if this is what the audience wants. Otherwise, I have got videos of surgery which I can share with you if that is more interesting. But I would very much want to know what are you looking for today, from what are you wanting to gain from today?
Hello. Yeah, everyone is interested in videos, madam. We are all obstetrics and gynecologists here.
Yes.
So everyone want to see the videos.
Okay, so why don't we, we were just talking about ureteric endometriosis. So there was this case which was done in my unit a few years ago, which was a case of ureteric endometriosis. Let me share that with you. Can you see my screen?
No, madam.
Okay, here. Can you see it now?
Yes, yes.
Okay. So this is a patient who had surgery by a person who was not a endometriosis surgeon. They found an endometrioma and they just drained it. And that was a few years ago. And then she started complaining of left-sided pain. And she had a stud. I will show you her imaging, but basically she had a ureteric stricture. And as you can see that there are a lot of adhesions to the left pelvic side wall. And these were divided robotically. And here you can see the ureter and how it is going inside into the, behind the uterus into the ovarian fossa where the ureter is completely strictured. So the first step, in what we do is we have a good look, we mobilize the bowel, and then we perform ureterolysis. So that is one skill which any endometriosis surgeon has to have, which is identifying the ureters. So if at that time when she had her previous surgery, if her ureters were identified and all the peritoneal disease was removed, she wouldn't have come to sort of this kind of a situation. So this is what we call the mobilization of the bowel. So to gain entry into the pelvis, you have to mobilize the sigmoid colon, both on the left and the right hand side. And that gives you access to the pelvis. And that gives you, helps you identify the ureters, as you can see. And once you have identified the ureters, the surgery, any surgery for endometriosis becomes easy. So I think for an endometriosis surgeon, because the pelvic side walls are so commonly involved, so being able to identify and isolate, you can see where the stricture is here, completely going inside into just above the uterosacral ligament. And this is just a very sort of, this patient had a ureteric reimplantation into the bladder because she had a decrease in her renal function. So that was just to give you an idea of, to show you ureterolysis and the advantages and how ureteric endometriosis can present. I can now show you some videos of hysterectomy if you want, on women with endometriosis. Let me bring them for a second. Just a second. If there are any questions, you can ask in between while I'm trying to get the video. Anything from the ureteric endometriosis? So the take-home message was, that the surgery for endometriosis should be performed by people who are happy and confident in finding the ureter and doing a peritoneal excision, as in excising peritoneal endometriosis. Because if 2 years ago this patient had the correct treatment, then she wouldn't have ended up with a ureteric stricture and needing such a major surgery. So just
Dr. Suruchi, it was a very nice demonstration. It was a robotic surgery or what was it like?
This particular one was a robotic surgery, yes. I'm now going to try and show you a laparoscopic surgery.
We would like to see some DIA as well. Infiltrating endometriosis and anything like bowel like this bowel shaving.
I think for, like I don't have any videos with bowel shaving at the moment. Let me see which one do I have. This one is again, like a hysterectomy in a woman with endometriosis. If you want, because I haven't sort of edited, I have those videos, but I haven't got them edited. So they are full videos, which will
whatever you have, you can show us, no problem.
So, and it's taking a bit of time to download.
We heard that you had developed some kind of a technique in endometriotic surgery. What is it? We want to hear from you.
Okay, let me share the screen. So basically, this is not me. I mean, I've worked, when I did my fellowship with Mr. Shaheen Khazali. And we together, we presented this in the conference. So this technique is basically his technique, but we, all the people who work with him, they sort of use this technique and it works very well. It's just if I can get it up on my screen. Why is it not opening? Because I maybe I have to minimize this and then open, and then yeah, now that is there. It is on my screen now, and I will share it with you. Share screen.
Anything else that you have it in readiness is okay. No problem.
So this is the technique, and it is called the so sure technique. And so what do you mean by so sure? So it is just a mnemonic which you can use, but basically when you go in, as I said, the first step should be to see what disease you have, and to maximize your vision, what you do is you survey the pelvis and you mobilize the sigmoid. So reflecting the sigmoid is the first part. The second part is ovarian mobilization. So as you know, both the ovaries and endometriosis are always very stuck to each other, stuck to the uterus. So you just mobilize both the ovaries by a combination of both blunt and sharp dissection. And then you suspend the uterus so that you have access posteriorly. And then you do the ureterolysis. And once you have done these things, then you can excise the endometriosis. So this is how to prepare for endometriosis excision. So when you are excising endometriosis, you need to make sure that two things are safe. That is the bladder and the bowel and the ureter. Sorry, bladder, bowel, ureter. These three things need to be safe. And then once you are sure that these three things are safe, then you can excise endometriosis. So this is a very simple mnemonic. So first have a look, then mobilize the sigmoid, then mobilize the ovaries, suspend the uterus, do the ureterolysis, and once you have done the ureterolysis, you can excise the endometriosis. So my next video, if I show you my next video, it will sort of bring this home. That is what we are doing. You will be able to understand what we are doing. So if just give me 1 second, if I can bring that video. while I don't have any idea why that video is not opening in this. The other one did open, but this one is refusing to open. That's the problem with videos. They sort of sometimes don't behave in the right time.
Okay. Maybe you can.
I can go back to my presentation, and if I can open the video, if I can show you the video. Yeah, I can, because that video would have, brought things to home, whatever I said about the socio technique. But unfortunately, these are huge, big videos, and sometimes they don't open when you want them to open. Don't want this.
It is in the cloud. Video is actually linked to cloud.
Yeah, I think that is the problem. And every time you download it, it takes a long time to download from cloud.
Yeah.
Can you see my screen?
Hear from you about your presentation.
So play from start. And now in my pictures are not showing. I don't know why, because it's all in, it is showing otherwise, but when I share it with you, my pictures are not coming.
No, you,
is that happen?
Oh no, we are not able to see your screen.
Yeah, stop
No,
sharing.
we can see your screen, but then no images.
I don't understand why it is not coming, the images, because I had put in a lot of effort and putting very good images in there. And without the images, it's not going to be so much fun. If you just give me.
Get the images open. Can you mail the presentation to us so we can try over here?
Yeah.
Yeah.
Just give me 1 second. I will just mute myself and see what is going on with this, okay?
Okay, fine.
Hello.
Hello.
Yeah, this is Dr. Sandesh. That what she is mentioning is a very, very excellent method that has come up, and the person she mentioned with whom she was working, Mr. Shaheen Khazali. Fortunately, we were together yesterday for 2-3 days here in France for this endometriosis conference. And Shaheen Khazali, the technique what they have designed is what exactly we follow in our practice as well now, is the So Sure mnemonic. And this is excellent method of preventing injuries to the ureter, bowel and ovaries. And more importantly, why we are not able to perform endometriosis surgery. Once she is ready, let us know. Hello.
You can continue, doctor.
Yeah. So
Doctor, tell us about the endometriosis conference that you had in France, and any some inputs, any updates?
The first input, I am not contradicting any speaker, is that AMH thing. See, AMH, we have to understand, is not the best method of diagnosing things. It is actually giving a lot of confusion. And we should not do AMH for 1 year after the surgery, because a lot of papers have come. People did a laparoscopic surgery for endometriosis, and then some did AMH after 1 month, some did after 3 months, some did after 6 months. So what was actually concluded was that if you do laparoscopic surgery, definitely the AMH is going to go down, but again the AMH will come up. Although it will take 6 months, 8 months, although it will not come to the original one, but it takes time for it to come up. Now, the most important and fascinating concept for me was they compared this ovary to a cherry tree. So in cherry tree, you have small buds, then these buds become flowers, that is cherry blossom. Then this, out of these many flowers, few will become green cherries. So these green cherries are like what we see on ultrasound, the antral follicles. And then out of these green cherries, few will become red cherries. That is, some will ovulate. So the buds and the flowers do not produce AMH. It is only the green cherries which produce AMH. Okay. So anyways, once you have done the surgery and now the next time the other buds are going to grow, that takes time and they are going to become green cherries and then the AMH will come up. So blaming it on, and what I have understood from this conference was, it was a unique conference for the first time for me is, it was together with the infertility specialist. What happens is in infertility specialist alone conference, you have a blame game of blaming, oh, these surgeons are very radical and they damage the ovary and all these concepts. I have come to a conclusion that we laparoscopists need to understand a lot of endocrinology, and the infertility specialists need to understand a lot of surgery and the possible complications. Okay.
Absolutely.
The problem that is happening now is every laparoscopic surgeon feels that he is an endometriosis surgeon, and that is creating problems. But of course, I believe everybody has to learn endometriosis, but I think endometriosis should be a supervised surgery, because just draining or cystectomy is not going to be useful. And more importantly, the EFI score, the second point which I found in today's presentation was EFI score, the endometriosis fertility index. Now this is excellent to give us whether the patient will conceive naturally or we should go early for the IVF. But unfortunately, in the EFI score, which is like up, you see 7 to 10 is a good score. But out of those 10, only 2 points are given for endometriosis. So it is not actually the clear-cut marker of an endometriosis score. It is about the tubes and ovaries and the patency and the historical factors are given more mark. So it is a good score, but it is not the only one for endometriosis. So it is still always preferable to learn the NZIAN, the hashtag NZIAN score. Okay, I think her video is on. I'll wait here.
Thank you, Sandesh.
Hello, Dr. Suruchi, are you there?
Hello, sorry about
Yes.
that. The video has finally uploaded, so you can see. So this is my sort of steps to follow in his women with endometriosis and ureteric involvement. And this will show you the steps that I was talking about. So basically, you know, this is the protocol that we follow. So you should do a good preoperative sort of workup for these patients. They need an advanced ultrasound, as I was talking about. You need to see where the adhesions are. And somebody who's very good at ultrasound will be able to tell that the things are stuck, the sliding sign is negative. Do an MRI. Then depending on if you think bladder, bowel is involved, then involve other specialists. Decide how big the uterus is, how big is the uterine size. And based on that, you know, put your ports, because the ports can't go anywhere. It has to be, if it's a big uterus, the ports all have to be higher up. Always start with sigmoid mobilization and bowel adhesiolysis. And then you maximize uterine mobility by freeing up the uterus and freeing up the uterus step by step, release the ligaments, free up the uterus a little bit more, and expose both the ureters so that, you know, you are sure that you're not injuring the ureter. Perform complete ureterolysis. Skeletonize both the uterine arteries so that you know where they are and there is no bleeding. And then once you have done all of that, then you excise endometriosis and perform the hysterectomy. So this video is going to demonstrate these steps in detail, okay? This video is of a lady who was in her 40s and presented with menorrhagia, dysmenorrhea, dyspareunia, and dyschezia. MRI for her showed that she had fibroids, adenomyosis, and endometriosis. Initially, we went in, the uterus seemed very bulky and not very mobile. So as we mentioned earlier, we started off with the easy things, mobilizing the ovaries, dividing the fallopian tubes because sometimes they dangle and can be quite annoying during surgery. Then we did the easy steps of releasing the ovarian ligaments, the broad ligaments, and the round ligament. And all of this gave us a little bit of mobility. All this while we were very cautious of where the ureter was. As you can see, doing these easy steps is making the uterus look more mobile. However, still the main concern is that there is a uterosacral nodule and the ureter is going right into the nodule and there is considerable fibrosis in the area. The right thing to do here is to spend your time and energy in mobilizing the ureter as much as possible. And as you can see very clearly here, this is a beautiful picture of water under the bridge. And you can see the uterine artery pulsating and the ureter vermiculating under the uterine artery. So this was the right-hand side. And in the left-hand side, I'm going to spend a lot of time demonstrating how to achieve this result, because I think that this is the most vital step in this surgery. And once you have achieved this kind of mobility and exposure of the ureter, suddenly your confidence boosts and you feel that you can now divide the adhesions and release and excise the endometriosis safely without causing any harm to the patient. Knowing your anatomy here is very important. The key thing to realize here is that along with the uterine artery, there can be veins. And if you injure the vein, it's no big deal, but it can cause a lot of annoying bleeding. So gentle handling of this arteriovenous complex is vital. However, skeletonizing this complex completely is also crucial because as you can see, the ureter is extremely close to this complex. And if you don't skeletonize it, then you may include the ureter while taking the pedicle. I'm just going to let you enjoy watching this bit of the surgery. And as you can see, with each step, the anatomy becomes much clearer. So you can see the ureter vermiculating down below, and it has been more or less completely freed from the fibrosis that was surrounding it. And now you can, once you have skeletonized the arteriovenous complex, you can decide how you wish to ligate, whether you want to wish to ligate it or clip it or coagulate it. And you can see how close the ureter is to the complex in, in women where there's fibrosis, it also comes really, really close to the uterine arteries. So that is why it is very important. In our case, as you can see, we are clipping, double clipping the complex and then cutting it. I can forward this a little bit. So that's just a demonstration posteriorly. And then you can see that suddenly the uterus seems much more mobile. You can ask questions if you have.
So you can see that here anteriorly is the easy bit, but posteriorly is the difficult bit. We always recommend doing the posterior bit first here, because if you do the anterior bit, then it becomes slightly difficult to attack the posterior wall, especially in these cases where there is a lot of adhesive disease and fibrosis. If you wish, you can use a rectal sizer here. We had done a per rectal examination and localized the site of the rectum. Now, once you have done the posterior aspect of the vault, the anterior aspect is really easy. All pray. It is usually present in this region and can bleed a lot.
So do you have any questions based on this? Because you said you wanted to see the video. This was just a demonstration of how mobilizing the sigmoid and moving the ureters away can facilitate your surgery.
It is a very fantastic video, madam.
Thank you. But I would like to reiterate that there is a lot of focus on the surgical aspect of endometriosis. What we really need to understand is what causes endometriosis and how can we screen for endometriosis maybe early on and prevent development of disease, which is of this kind of disease, which is really bad and very painful for women. So what we are looking at here in St. George's is what is the role of autoimmunity in endometriosis? What is the role of genetics in endometriosis? What we have found is that endometriosis is associated with a lot of other autoimmune diseases. So, whether we can give treatments which are used for autoimmune diseases for endometriosis and whether we can find some kind of correlation in the genetics of endometriosis. But what we are finding is that there's wide variation between populations and there are no particular genes that we can say that these are the 4 genes associated with endometriosis. What we are finding is women with endometriosis who have infertility, they have got a separate genetic setup. Women who have endometriosis, deep endometriosis, they have separate genetic setup. So we are still a long distance away from doing a blood test and doing a genetic analysis and saying you are at a high risk, you can go on preventative therapy. But that is ideally what we should be looking for. I think for long, hundreds of years, people ignored endometriosis. Then for hundreds of years, the focus has been on the surgery for endometriosis. While this is fascinating surgery, but at the end of the day, what we fail to realize is that this woman has suffered all her life and she has had such bad disease. What can we do to prevent her from getting to this stage? That is where the focus in the world is. And then especially for women in India, I think, women in India are often ignored, often not listened to. And we as gynecologists who work in India, they have a special responsibility to give these women the care and the respect that they deserve.
Thank you so much, madam, for an insight in endometriosis. It was a very wonderful lecture. Thank you so much. Now we are heading for the second lecture.
Hello, a very good afternoon to everybody. Now we proceed with our next talk in the session by Dr. Mohammad Mubram. He is a consultant gynecologist in Cambridge and London. Now he is going to talk on the subject of bowel endometriosis, where to look, what to treat, and how to treat. Sir, may I request you to talk deliver your lecture now?
First of all, thank you very much for the kind invitation. It's a real pleasure and an honor to be here amongst you. I hope you can hear me well. Okay, so and thanks to Priyanka, who is my fantastic colleague here in Cambridge, who gave me this opportunity to be here with you. And today we will be speaking about bowel endometriosis, and I think my colleague who has just finished a fantastic lecture about the approach to endometriosis has just made my life easy. Because I will definitely almost say the same things as she said. So I have no conflict of interest related to what I'm saying today, and I will just try to discuss with you the decision-making about bowel endometriosis, how and which technique do we utilize for this. So starting from the decision-making for bowel endometriosis, if we start by asking ourselves, what's the evidence? Do we have a strong evidence to support what we are doing in these ladies, and the surgery that we do, the shave, the segment, the disc? Is there a strong evidence? Is there a randomized control trial or a systematic review of literature or meta-analysis that supports what we do every day? Well, if you look to the Cochrane reviews, you will find answers to difficult questions, but everything but surgery. So you will find Cochrane reviews about medical treatment, herbal treatment, acupuncture, Chinese therapy, but you will not find an answer to this. If you check the NICE guidelines that are published in 2017, and you try to find an answer to this question, is there a strong evidence to support all what we do? The answer is no. And maybe the ESHRE guidelines would give an answer. And if you look to the ESHRE guidelines 2014, and what they said is that clinicians can consider performing surgical removal of deep endometriosis as it reduces endometriosis associated pain. But look to the ESHRE 2022. They said, yes, clinicians can consider because it may reduce. So even when I had a discussion with my colleagues who issued the ESHRE guidelines and were participating in its preparation, they said, yes, Mohammed, because of lack of available evidence. So even they changed the wording from it reduces to it may reduce. So, and if you look to this paper published on the British Journal of Obstetrics and Gynecology in 2017, where they compared the national and international guidelines over 152 recommendations, you will find an agreement only in 10 of them. So 7% were comparable and the rest were not. So there is a substantial variation in the recommendations and the methodological quality of endometriosis guidelines, and we know this. So here we come to another concept for dealing with endometriosis, which is value-based endometriosis or value-based care. We aim at lowering or reducing the low-value care in endometriosis because we know by definition that if we offer a randomized, there is a nice paper by Vercellini and his colleagues where they tried to questionnaire the patients, are you happy to be randomized to medical treatment or surgical treatment for endometriosis? And only 2% of 500 patients said, yes, we're happy. So by definition, it's not easy to make a randomized controlled trial for surgical treatment of endometriosis. So what we need to do is, if there is an intervention with a potential benefit and well-established risk, then we have to think about it. We have to think about it because we may be offering a low value care to this patient, and we will see what and how. So if you ask me, okay, Mohammed, I have been privileged to treat patients with endometriosis for the last 18 years of my life in two of the biggest centers in the world, in Italy, in Bologna University and in Negrar. And I've always asked this question to myself. Is it because this is a new disease? Is it because no one knew about it before that we are in this dilemma? The answer is actually not. It's not that new. And the first papers that have been published about this disease was in 1946 and 1947. So it's not something new, but it's a particular disease, as my colleague has just said. Decision-making in endometriosis, especially deep endometriosis, especially bowel endometriosis, is a real challenge. Because we need to have clinical criteria, we need to listen to our patients, we need to understand them, we need to understand exactly what their problem is. Is it fertility? Is it pain? Is it quality of life? And again, I will cite what my colleague has just said. In some cultures, in some societies, the pain and the menstruation is just a taboo. You have pain, well, that's fine, it's normal. And the care that's offered for these patients is not usually the same among the different cultures and different countries. Ultrasound diagnosis, she has just said expert ultrasound, but how expert could be? This is a question. We don't have Caterina Execustus and Luca Savelli and Tom Bourne in every hospital. And even the MRI is a good tool, but it's very much operator dependent. And in my career, I've seen a lot of MRIs that were reported as negative. But actually, the patient has a lot of parameter endometriosis and retroperitoneal disease. And then the question comes, diagnostic laparoscopy, and this is what has been described as the gold standard for diagnosis in many guidelines. And actually, fortunately, 2022, the ESHRE guidelines wrote it very clear. Diagnostic laparoscopy is not the gold standard for diagnosing patients with endometriosis. We have very good diagnostic modalities. We have good ultrasound, good MRI, good clinical background. And if we do diagnostic laparoscopy for a patient with deep endometriosis, this is not a diagnostic because it's in another room. It's in the retroperitoneum, and we look for the disease in the intraperitoneal cavity. So to answer the questions that I've been asked to answer, where, how, and what, I think we need to think endometriosis. We need to think endometriosis because we know that endometriosis is a global disease. It affects young women in the reproductive age, and it's a benign disease. We need, more importantly, to understand the disease, to understand the patient's objectives, and to make a precise diagnosis before offering any surgery to this patient. We need to counsel the patient very appropriately and help her to make an informed choice. Yes, in endometriosis and hopefully in other parts of medicine, in modern medicine, we don't decide for the patients. Especially with endometriosis, again, it's a benign disease. We give the patients as much information as we can, and we help her to make an informed choice. And here, the surgical skills at the end, if we can, or if this patient really needs surgery, this has to be done by a surgeon who has skills and training. This is something that is obvious, and I don't know why being a gynecologist and having a license to practice allows everyone to operate on deep endometriosis patients, and then we find a patient with 17, 18 surgeries, where then she arrives to have a complete radical excision of her endometriosis. And here the other question. So what's the best approach for patients with bowel endometriosis? The best approach, in my personal opinion, and not only in many of the experienced or centers for endometriosis, is a holistic approach to the patient, a tailored approach, that we tailor the treatment to the patient and not a lesion-oriented approach when we focus on a lesion and we try to remove the lesion and thinking that by surgery only we will solve all the problems of these patients. So our aim from our surgery is to improve pain, optimize fertility, and there are some absolute indications, let's call them like this. If there is a suspected malignancy, or if there is subocclusive bowel stenosis, or if there is urethral stenosis with hydroureteral nephrosis and risk of kidney damage. Apart from this long list of perioperative complications that might happen to this patient, there are also important dysfunctional complications that can happen, especially this is a young patient again, and the delayed functional outcomes are now very much stressed upon when we speak about surgery with endometriosis. So here, which technique? We have actually three techniques or three basic things that we can do for bowel endometriosis. Either shave when simply when the lesion is superficial to the and not invasive to the muscle, or partially invading the muscle, and this is where we can shave this nodule without getting inside the cavity, or a disc resection, where anterior disc resection, where there is a small nodule less than 3 centimeters that's invading the muscle wall of the bowel, or if there is significant stenosis or a lesion that's more than 3 centimeters, or repeated surgeries, or circumferential lesion, which is very rare, we then resort to segmental bowel resection to remove the segment of the bowel and do end-to-end or lateral anastomosis. So these are the three options that we have, but deciding again is not very easy, because we have analyzed 1,390 patients where I was still working in Bologna, out of which 392 patients were in the gray zone, which is before surgery. In many patients, we know either by transvaginal ultrasound or by MRI, patient's symptoms and her history, more or less, if she's at high risk for segmental resection or at low risk for segmental resection. And there is a gray zone where you just explain to the patient that we will go inside, we will operate on your bowel, and we will do 1, 2, or 3. And out of these patients, 392 patients, there was a high percentage of the patients that has been treated with rectal shave. And obviously, you can tell that the patients at the end who had minimally invasive was less invasive or shaving had lower incidence of perioperative complications. And this was not only our opinion, many other colleagues, especially the team of Negrar, which have, let's say, for the first time focused and made a comparative study about nerve-sparing surgery. And they found that among 136 patients, discoid patients versus rectosigmoid resection, the discoid had less incidence of nerve dysfunction within the 30 days after surgery. And then comes the other question. If we do a segmental bowel resection, I witnessed surgeries where we used to do this large resection of the bowel, yes, because there was a main lesion, and you might find at 3 to 5 centimeters another satellite lesion. So we used to do massive or almost a hemicolectomy. But in 2012, we published this paper on human reproduction where we evaluated this big resections in comparison to a centimeter above and a centimeter below from the main lesion. And we found that there is no statistically significant difference in terms of anatomic recurrence, pain recurrence, or quality of life. And this is why we started to move from these left hemicolectomies to what many of the surgeons in some centers around the world now speak about, like conservative radicality or economic radicality, where then we speak about surgery and how we do surgery. We have some important concepts. And in these concepts, I would like to highlight the first one, which is we need to do one successful surgery. If this patient is about to be operated, and I agree, I'm a surgeon, I operate the patients that arrive to me, most of them need surgery and have been operated once, twice, or 3 times. My point is, if this patient needs surgery, then our aim is to do one successful surgery, as complete as possible of the disease and as conservative as possible on her organs and nerves. It's a one successful surgery. Again, we have to be patient-oriented, not lesion-oriented and not ego-oriented. I need to focus on what the patient needs. Is her objective a pregnancy? Then yes, it's a collaborative work with the fertility doctors to achieve her objective. And if she needs to have improvement of her pain or quality of life, this is another issue. And definitely giving the patient as much information as we can. And we help this patient to accept what she's going through and to make an informed decision. The decision, we have to counsel the patient that this decision can be changed during surgery. So we might be going for a disc and then we do a segment. Not all the patients need ileostomy or stoma. And this is where we don't have to frighten our patients and say, yes, you will do this and you'll have stoma. But we have to do personalized counseling to every patient. It has to be tailored in surgery and in counseling. And I will never be able to stress enough the importance of the multidisciplinary approach and in specialized centers. It's not a one-man show, even if in some centers, like centers that I have been privileged to work in Italy, there is the concept of a pelvic surgeon that does, I have a very good friend of mine, and I'm sure all of you know him, which is Mario Malsoni. He does his endometriosis, his segmental resections, his anastomosis, his stoma, his ureteric reimplantations, and everything by himself. But if you don't have the authorization to do this and the sufficient training to do this, it's much, much, much better to work in a multidisciplinary approach and in a center that can offer a 360 degrees care to these patients, not only the surgery. We are not technicians doing a technique. And this is why now, again, the concept of nerve-sparing surgery is not optional in these situations. And as you can see in this paper published by Mark Possover in 2012, and I think this is one of the best papers that discussed this topic of the bladder dysfunction after surgery, you can see that the mean time between operating a patient and having an irreversible myogenic damage of her bladder muscles is 9 years. So it's not only the post-operative evaluation of residual volume of urine, it's some time that passes between your surgery and this patient then has unfortunately irreversible damage of her bladder and she needs to self-catheterize herself. So just a quick note about nerve-sparing surgery. We know by definition that deep endometriosis is a neurotropic disease, so there is an element of neurotropism and neurotrophism, and that deep nodules are infiltrated by nerves and nerves are infiltrated by deep tissue, deep endometriosis tissue. And this is why not only somatic nerves and sensory nerves, but also autonomic nerves are affected. And here you can see how we start our surgery, however, and how deep this endometriosis is. We start far high in the pelvis and we try to identify the nerves first before starting our surgery. Pelvic splanchnic nerves coming from S2, S3, and S4, the hypogastric nerve that carries basically sympathetic innervation, and they join together to make the inferior hypogastric plexus. And then we create this window and we operate interfacial, do interfacial surgery, conserving again as much as we can the nerves and the function, and being as complete as possible on the disease. Here, this is an example of segmental bowel resection. And here, as I was just saying, it's where you operate interfacially and trying your best to conserve the nerves. And no need to isolate them nerve by nerve if they are not involved, but it's just the preparation of your surgery that makes a little bit of a difference. We actually published this paper in 2019 on the JMIG, where we, together with a team from Canada, from Toronto, with Dr. Nocelio Lemos and another team from New York, where we did cadaveric study and other evaluation on live humans to draw a sort of a cartography for these nerves and how to identify the nerves before starting the surgery, where exactly to open and how to move to achieve nerve-sparing surgery. And we are not the only ones. There are a lot of, we also published this in a sort of a video article, and there are many other colleagues who published standardized technique like the Negrar method and Horace Roman and other colleagues. So coming to the conclusion, we need to do tailored surgery with personalized approach. Our surgery should be patient-oriented, not lesion-oriented, and not ego-oriented. We have to be conservatively radical as much as we can. Radical on the endometriosis, one successful surgery, conservative on the nerves and the organs. And we aim at function-sparing surgery. We need to have a method, and we need to work in a multidisciplinary team. And again, it's anatomy, anatomy, and anatomy. And thank you very much for your kind invitation and for your attention. Thank you.
Thank you so much, sir, for your information and excellent talk on the bowel endometriosis. You have very nicely enlightened upon how to do the surgeries in case of mild variety with only shaving, and with a deep infiltrating variety with a discoidal or segmental colorectal anastomosis. And it should be like patient-oriented, and with multi-specialty disciplinary hospital, it should be undertaken. Very nice, sir. Thank you so much for demonstrating and sharing all your excellent videos with us. Thank you once again so much.
Thank you for the kind invitation.
Can I have one question?
Yes.
Yeah. In your experience, Dr. Mohammed, how often do you how often it happens that you tell the patient you will do a resection and then you land up with a discoid excision? The question I want to ask is, are we getting over diagnosis with sonography or MRI? I mean, like, when has this happened, either with sonography or MRI, and which modality is over diagnosing or under diagnosing? It's not a problem, but we actually need to understand, and what you follow in your protocols. Do you depend on only sonography or MRI? As like many centers in Italy do only sonography, while in Horace he does MRI only. So what is your protocols?
Well, thank you very much for this question. This illustrates exactly what I wanted to say. So I used to work in Italy, and I've been privileged to work in super centers for endometriosis for 15 years. So in these centers, we have very, very good schools for ultrasound. And I remember the days where I used to justify why I order an MRI. So you have to write a justification, because this is a cost, and this is something that you have to write a justification for it. And we used to base everything on ultrasound. Ultrasound is really operator dependent, and eyes do not see what mind does not know. So if you have, again, these big names that do ultrasound, you can do ultrasound. But with time, I tell you, you asked me about my personal experience. I learned ultrasound scan, and I don't operate a patient without scanning her. Why? Because this gives you, if it doesn't make a proper diagnosis and describe millimeter by millimeter, it gives you an idea of how the situation is inside. The dynamic property of the ultrasound, and how you move and how you do the sliding and how you imagine, it helps you to imagine how the pelvis is inside. In the UK, it's more MRI dependent where I work, and I have to say the truth. I'm very privileged that I have a fantastic radiology team here. They're very, very skilled, and they describe the situation very, very precisely. It helps very much before surgery. Also in the MDTs, where we have pictures, where we have the radiology, we do very detailed MDT discussions before deciding for every surgery. And we base on MRI. MRI describes the situation in very details, and this is an advantage and a disadvantage. An advantage because you know everything, and it's rare that they make underestimation of the disease. A disadvantage because they write here 2 millimeters here, 2 millimeters there, 3 millimeters here, and then you find yourself, first of all, if you're not very well experienced with the disease, you can, the patient gets scared and the doctor gets scared, and they say, oh, you need a mega surgery right now, you need to remove the uterus, everything. But actually, this is not that bad. The situation is not that bad. And it's good because it describes everything and helps you to counsel the patients. And I really appreciate them when they do the 3D reconstruction and show you how far it is from the sciatic nerve, for example. And this helps very much in preparing for the surgery with a peripheral nerve surgeon, with referring this patient to a neuropelviologist, and I believe that if you have in your center a good MRI service, this is a gift from God. I hope I answered the question.
Yeah, thank you so much.
Pleasure.
And a good news for you, I am actually in Horace conference here in France, Tivoli, Bordeaux. And good news for you is that in many papers you have been quoted. So I really appreciate it. I'm happy that you are presenting it for my local society today. A great honor for us.
It's an honor. Unfortunately, I missed Bordeaux because I was in my home university in Alexandria. And these are, yes, congresses where you cannot refuse, you cannot say no. So, yes.
Thank you.
Thank you very much.
Yes, thank you, Dr. Mohammed, Dr. Suruchi. It was our privilege to have you with us today in Solapur OBGY Society. Thank you so much.
A pleasure. Thank you very much for the invitation.
Inviting us. Thank you.
Hello.
I request our chairperson and Anjali ma'am, please felicitate Dr. Suruchi ma'am and Dr. Mohammed sir by e-trophy. Ma'am, please accept this trophy virtually from our society.
I'm sorry. Hello? I cannot hear. Hello? Can you
Hello,
hear me?
sir.
Yes?
Yes. Sir, this is a virtual e-trophy for you on the behalf of our society.
Oh, thank you very much. Thank you very much. Thank you.
Thank you, sir. Can you see it, sir?
I can, and I'm very thankful and grateful for this. Thank you very much.
Oh, thank you, sir.
That's so kind of you.
I request Anjali Jama ma'am, please felicitate our chairpersons. It's great privilege to give vote of thanks for attending the CME and making this conference outstanding because of our great faculties and great audience, of course. I thank Dr. Milind Shah sir, Dr. Bharat Jain, Dr. Shweta Raje, Dr. Manjuri Valsankar, Dr. Kalyan Balmare, Dr. Sandesh Kade, Dr. Rohini Deshpande, Dr. Umbardan sir, Dr. Dable sir, Dr. Suruchi, Dr. Mohammed Mabrak, and special thanks to Priyanka Deshpande for arranging this conference with international speaker from NHS UK and our chairpersons. I thank the SOGS for attending the CME in large number. I thank AMOX Infertility Committee for giving the responsibility to SOGS to plan this CME, and I thank Anjali ma'am and whole SOGS office bearer. Last but not the least, our pharma partner Alembic and Balaji Sarovar for giving us beautiful venue. Thank you everyone from the bottom of my heart.
Madam, thanks to you.